for all that He's done for me. Meshiranidi, Medinadansi, Wania, Oye Mamita, Meshiranidi, Medinadansi, oh, Wania, oh, yeah, Mamita.
Good morning. Good morning.
Good morning.
Distinguished guests, ladies and gentlemen, good morning to you all. And very welcome to the strategic stakeholder engagement meeting on implementation of the Ghana Medical Trust Fund, also known as Mahama Cares. Welcome. Please, let's flow with me. When I ask, you respond. Or we've not eaten. We have breakfast and we eat soon. Okay, to begin with our program, let's first invite Solomon to give us the opening prayer. We have to start with prayer. Oh, another one. I was saying, I said in Bible. Is that your sorry? Hello. Hey.
No pale, no pale.
Yes, okay.
Yeah, no pale.
No pale. Sorry.
Thank you very much. Shall we pray? Our gracious and eternal God, we thank you so much for life. Indeed, you are the shepherd and overseer of our soul. We commit this short period of deliberations unto the care. We ask, O Lord, that deep prayerness come in our own way in the midst of your people. Let there be impartation of knowledge and wisdom in our midst. Let us live here with the plan of Jacob for the betterment of our nation, Ghana. We thank you that in the end we shall be careful to give about the praise and glory once again. In Jesus' name. Amen.
Amen.
Okay, amen, Solomon. Thank you very much. We have to introduce ourselves. Like I said, you don't know me, I don't know you. Or you know me. You don't know me. But I know some of you. And we don't know ourselves, so we introduce ourselves. I'm just Barbara Bialkai from Atenka TV and Buya TV. Which my friend is here, my media station in Maka Fanta Kakra, Maka and Kakra, and Makabra for Kakra. It's not say, Jimmy I eat you. Lay person, and I don't want to say. You have to performance, your car. Now, you would get or more. Now, more passions, and because, like I said, they are more firm, opposite thing. So we will be mixing them so that when we go back, we can tell them what really happened. Agree?
Agree.
It's my mommy, your friend saying, Jesse, or Edubia. Thank you so much. Today, from now to the time we close, I'm going to be your servant. If you need money, call me. Yes. If you want to go for shopping, call me. If you want school fees, call me. Anything at all, just call me. Just raise your hand and I'll come to you. So pass the microphone. You're holding here. I'll come there.
My name is Abdul I work with the Ghana My name is Christopher Gbega. I'm with the Ghana Institute Alliance.
My name is Victoria. I'm from Atenka TV.
My name is Yabi Beambo from Cinema Technology.
I'm someone with NCD control for the Ghana Health Service.
Well, it's only a program manager at the Ghana Health Service.
Patience, Dapa, Human Language, National Development Planning Commission.
My name is Abdul Karim Yusuf, and I'm the Minister of Health.
I'm Sandwich about the business and the business and financial terms.
Good morning. And today is CNS Yama from Ministry of Health, Policy Planning and Monitoring.
Good morning. I'm Juliet Onyami from the Ministry of Health, Better Data.
Good morning. My name is Aditya Abdullah from Ministry of Health, Public Health Promotion.
My name is Catherine Perigo from Ghana Endo Charity and Ghana NCD Alliance. Thank you.
My name is Zulaiha Tumaku, SPH, School of Public Health, the Bioexist.
My name is Doris Ampon, representing the Alliance for Reproductive Health.
Madam Abdul Fattah from the Federation of Community Organization.
Okay, so I'll do the rest of the introduction myself. So I'll skip some. Okay. Oh, yeah, on that. I said okay.
Okay.
Oh, clap for me, clap for me. You don't like me, so I don't want that to be boring. We are planning, so I was saying, we should be happy to do that. And I'm about to breakfast. They should bring it whilst we work, or we should do it before. Okay, thank you very much. So we'll take our welcome statement, and that will be done online. Yes, so I will read a short profile. In fact, the profile and also finance, so I'll cut it. And because of time, so that we can move fast. Dr. Mrs. Patrice Biafe Adai, MD, PhD, is a pioneering Ghanaian medical professional renowned for their expertise in breast pathology, surgery, and oncology. As the first female specialist general surgeon in Ghana, she has dedicated over 3 decades to combating breast cancer through clinical practice, advocacy, education, and philanthropy. She serves as a founder and president of Breast Cancer Care International (BCI), a non-governmental organization focused on breast health awareness, and as the chief executive officer and senior consultant breast surgeon at Peace and Love Hospital in Accra and Kumasi. Specialist facilities she established to address breast cancer and related diseases like cervical cancer, eye care, and renal diagnosis. Her work emphasizes early detection, pre-screening, and comprehensive patient support, driven by the high rates of late-stage breast cancer diagnosis in Ghana and personal encounters with affected women. Awards endorse degree, and positions endorse degree. I can't mention them all at YRT. We invite Prof. Dr. Mrs. Patrice Biafe Adai, or we find online element. So. Okay, we are trying to get her. She's still not ready. So we skip that because one of our guests wants to attend to equal meeting like this. So we'll take her profile so that she will take over and go on. So we'll take the technical presentation by, and the person to do this for us is a seasoned administrator, a journalist, That's fine. So we take our key note statement and we are taking it from the first one from Minister of Health. So the Honorable Pabna Akando is a Ghanaian Minister of Health appointed in February 2025 under the Mahama administration. As a member of parliament, he brings a strong legislative background to health policy, focusing on ending inequities like the low culture in healthcare delivery. He has championed transition in health purpose, including USC expansion, NCD integration, and resource mobilization via funds like MahamaCares. His priorities include primary care improvement, anti-corruption in facility, and sustainable financing to combat NCD's burden. In recent addresses, that of November 2025, he emphasized purpose-driven reforms for equitable access. He recently led Ghana's delegation to the just-ended fourth high-level meeting on NCDs and mental health network. Okay. I think he's not here, but someone will do it with have. Is it Ignatius? Mr. Ignatius, right? Okay, so please let's give that.
Relax. On Thursday, we'll have the Black Star Experience launched. At this time, you can do the round of applause. It is now my distinct honor to respect Dramani Mahama. Please, shall we rise and give him a thunderous applause as he comes to stage to speak to Ghana?
Can you please remind me of your name again?
Our sister here, I mean, very touching.
Trying to
And maybe I'll make a few remarks before I inflict exactly what the minister said. But I want to say I can empathize with what she's going through. It was a disease for the rich. Hypertension, cardiovascular diseases, diabetes were diseases of the rich. But increasingly, we see that it's inflicting more the persons who are much poorer and can least afford to be able to manage those diseases. And that's why the Ghana Medical Trust Fund has come at the right time. I have a personal connection to non-communicable diseases. And that is because my father died, mother died in 26 and diabetes. My stepmother died of breast cancer.
the Ministry of Health,
I lost a friend, I'm sure most of you know, Mama Nadumo, whose son is in his 30s and is on dialysis.
and of course that
He's suffering
restrictor
kidney failure.
and
And so
officials
these
of
are
the
not
Medical Trust
things that are far away from us. These are things that are close to us. These are loved ones that we're talking about. And so like prosciuttis, we must not see them as statistics. We must see them as real lives that we need to touch and help. But there's the even sadder story of one of my
organized jointly by the Ministry
confidants
of
and strong
Ghana
supporters when I started this whole political journey.
last year,
He was an assemblyman
when His Excellency
and he was an executive of our
John
party,
Dramani
Lebanon,
Mahama
where
launched
I started
the Ghana Medical
political
Trust
career
Fund,
as a
the
member of
ambition
parliament. Very close to me.
transformative pillar
Went
within our
everywhere
national
with me
health
anytime I
financing
went
framework,
back to the constituency.
ensuring that
He
no
was in charge of the
Ghanaian
southern
suffering
zone,
from
and so
chronic
anywhere I
non-communicable
went, he went
diseases
with me.
is
And
denied the
a
need
few
to
years
care
back,
because of cost
he
or
started to
location.
have a problem with his kidneys.
It is an
And
initiative
so
that
at the
embodies
time,
the government's commitment to
there was no
building
dialysis
a compassionate,
north of Kumasi.
inclusive, and resilient
And so
health
if you
system.
had kidney failure
MahamaCares seeks to
anywhere
complement the national
above
insurance scheme by covering treatments and medicines for non-communicable diseases that over the years have received funding under the National Health Insurance Scheme benefits package. These conditions, including cancers, cardiovascular diseases, chronic kidney failure, stroke, and other lifelong NCD conditions, that demand sustained and specialized care will now be adequately funded through the MahamaCares. By providing financial assistance to patients, the fund will also invest strategically in the provision and maintenance of essential medical equipment, specialized training, medical research and innovation, and infrastructure development to strengthen health facilities nationwide. As earlier mentioned, the Fund Secretariat, under the capable leadership of its administrator, Madam Obobia Dakuboku, has begun nationwide needs assessment in selected hospitals, identify gaps in diagnostic capacity and specialized training. These actions are part of a broader agenda to ensure that interventions are both evidence-informed and also sustainable. As government, we are also advancing the free primary care policy, which together with the MahamaCares forms the backbone of our drive towards universal health coverage. Both initiatives reflect our determination to remove financial barriers, to expand access, and ensure that every Ghanaian can receive the care they need, irrespective of income, gender, or location. Ladies and gentlemen, the passage of the Ghana Medical Trust Fund Act 2025, the appointment of an administrator, and the constitution of the board demonstrate government's commitment to the new era in health financing. However, let me acknowledge that its success will depend on collaboration and support among government and its agencies, civil society, government partners, and our communities at large. I therefore commend the Ghana NCD Alliance for collaborating with the ministry to convene this dialogue. The ministry welcomes this partnership and remains committed to ensuring that the implementation of the MahamaCares is guided by principles of equity, accountability, and sustainability. As we deliberate today, let us remember that MahamaCares is not just another policy, it is also a social contract with the Ghanaian people. Its success depends on sustained collaboration among all stakeholders represented here. Hence, let us use this platform to align our efforts, explore funding opportunities, and share insights that will make the Ghana Medical Trust Fund a lifeline for families burdened by chronic illnesses. I want to thank you so much for your listenership. Thank you very much.
Thank you very much. Dr. Ignatius. Your surname, unless you help me with it. Are we Bono? Okay, he's the director, Allied Health, MOH. Thank you very much, boss. Okay. Solomon, can they do something about it? This church. Okay, so our welcome address is ready, so let's take it.
Distinguished guests, esteemed colleagues, ladies and gentlemen, please forgive.
The one we're supposed to take online. Yes.
Distinguished guests, esteemed colleagues, ladies and gentlemen, please forgive my inability to be with you in person this morning for this very important event. This distinguished guests, esteemed colleagues, ladies and gentlemen, please forgive my inability.
The sound of it. The sound is just.
Okay, so we skip that. All right, so the main reason why we are here for us to have a critical technical look at the Mahama case. That's why we are here. And the person to do this presentation for us is a seasoned administrator, a journalist, a philanthropist, and a public servant appointed in August 2025 as head administrator of the Secretariat for the Ghana Medical Trust Fund, Mahama-Cares. In this role, she oversees the fund's operations, focusing on sustainable financing for specialized medical care, including NCDs through innovative revenue streams like public-private partnerships. Previously, she held leadership positions in aviation like Ghana Airports Company Limited and media, bringing expertise in policy implementation, stakeholder engagement, and resource mobilization. Known for her empathetic leadership, she has led courtesy calls to hospitals and regulatory bodies like the Petroleum Commission in October 2025 to foster collaboration for health equity. Her work aligns with Ghana Universal Health Coverage, UHC, goals by 2030. Ladies and gentlemen, please help me welcome Madam Ogoria, head of the Secretariat, Ghana Medical.
Thank you very much. Directors of the Ministry of Health, technical advisors, heads of agencies and institutions, distinguished guests, ladies and gentlemen. This is a deep honor and a privilege to stand before you this morning at the strategic stakeholder engagement on the Ghana Medical Trust Fund, commonly known as Fund-MahamaCares. Today's engagement is not just another meeting. It is a gathering of minds and hearts committed to building a health system that reflects the true spirit of compassion, equity, and national responsibility. In the last 8 weeks since I assumed office, I embarked on an extensive needs assessment with my team across regional and teaching hospitals in the country. What we found was deeply revealing. Across our regions, we met doctors, nurses, and other health practitioners who continue to give their best under very difficult circumstances. Professionals of remarkable skill and sacrifice. Yet, behind their courage lies a difficult truth. Many of our health facilities are struggling without the critical tools required to manage non-communicable diseases. It is devastating. We discovered that in several major hospitals, CT scans have broken down and remain unrepaired for years. Others have no MRIs, leaving patients to travel long distances for diagnosis. Dialysis units are overburdened and not available sometimes, forcing patients to wait in vain or forgo treatment altogether. It is surprising to note that across the entire country, there are only 3 radiotherapy machines, one in Collective Teaching Hospital, the other in the Confanoche Teaching Hospital, and one in a private facility. These are not statistics. These are realities that define whether someone gets the chance to live. Every broken machine, every missing facility represents not just a technical gap, but a human story. A mother, a father, a child waiting for hope but too often comes too late or doesn't come at all. The Ghana Medical Trust Fund, established by Act 1144, was created to respond to these very challenges. It was born out of a simple but profound belief that no Ghanaian should lose life because they cannot afford care or because the right equipment is too far away. Envisioned by His Excellency John Dramani Mahama, the Ghana Medical Trust Fund stands as a promise to bridge the gap between need and access, between awareness and action. It complements the National Health Insurance Scheme by focusing on chronic non-communicable diseases such as cancers, kidney diseases, cardiovascular illnesses, conditions that quietly but steadily take a heavy toll on families, communities, and our nation. Our work is guided by 4 strategic pillars: financing specialized care for chronic and non-communicable diseases, investing in essential equipment and infrastructure across our regional and teaching hospitals, training specialists and building human capacity to ensure quality healthcare in every region. Last but not least, supporting research and innovation to guide sustainable and evidence-based healthcare delivery. In pursuit of these strategic objectives, the Ghana Medical Trust Fund has also initiated engagements with corporate institutions across the country to explore avenues for meaningful collaboration. The feedback from these discussions has been overwhelmingly positive, reflecting a shared commitment to strengthen healthcare delivery in Ghana. These partnerships will help us to mobilize additional resources, complementing the fund's efforts to equip hospitals, support specialist care, and expand access to critical services. By fostering such collaborations, we are creating a collective framework where government, private sector, and civil society can work hand in hand to ensure that essential healthcare reaches every region efficiently and sustainably. But ladies and gentlemen, as ambitious and necessary as this vision is, we cannot do this alone. This fund will only achieve its true impact if it is shaped by the collective wisdom, experience, and expertise of stakeholders like you. Your institutions, your insights, and your voices are central to its success. That is why this engagement is so important to us. We are here not to present, but to listen, to learn from you, to hear your perspectives, and to co-create a roadmap that truly works for Ghana. We invite you to share your ideas freely, to ask questions, and to challenge us to do better. The Ghana Medical Trust Fund belongs to all of us, and its success will depend on how effectively we can build partnerships across government, the private sector, civil society, and our development partners. Ultimately, this is about building a future where a diagnosis no longer equals despair, and where every hospital in Ghana has a capacity to detect, diagnose, and treat. When we strengthen our healthcare system, we strengthen our workforce. When we save lives, we sustain productivity. And when we invest in the health of our people, we secure the future of our nation. Dr. Nobeki Ogen, who happens to be my health policy advisor, will take us through a detailed presentation on the operational framework of the Ghana Medical Trust, its strategic priorities, and the various partnership
that exists for all stakeholders gathered here. It will also provide deeper insight into how we can work together to ensure that this fund delivers measurable, life-saving impact across the country. And always remember that truly Mahama cares. Thank you very much.
Thank you very much. Please let's clap. Okay.
Good morning to you all. Good morning. Good morning to you all. Good morning. We are glad to be here and to have this stakeholder engagement. The Ghana Medical Trust Fund is very important in bridging the gap, complementing the National Health Insurance Authority and helping us achieve universal health coverage. So it's good that as stakeholders we gather to discuss about the implementation framework of the Ghana Medical Trust Fund, where we can all share input and ideas on how we can make this better and beneficial to all Ghanaians. So we have a vision. We envision a healthier society pursuant to universal health coverage, where every citizen has access to specialized medical care for the management and treatment of non-communicable diseases, regardless of their location, social, and economic status. So you notice that there are some components that are very important which I want to highlight. One is non-communicable diseases. So this already gives us an idea of the kind of conditions we'll be dealing with. If it's not communicable, it's non-communicable. So we'll be dealing with the conditions that, broadly speaking, we do not transmit to another person. Conditions that are born out of lifestyle changes, our activities, inactivity, and certain things that happens such that we cannot transfer those diseases to people around us, either through contact, airborne, or what have you. Also, it highlights specialized medical care, and this sets us apart from the other health agencies which are involved in health financing. So we will be dealing with specialized medical care because these chronic non-communicable diseases at the earlier stages, it will fall under primary care, it will fall under National Health Authority. But once it gets to a certain level, once it becomes chronic, it becomes severe, it puts a heavy burden on families, then it will require some specialized care, and that's where the Ghana Medical Trust Fund comes in. The Ghana Medical Trust Fund was set up because we have a challenge on our hands, and as the Alliance for the NCD Alliance Ghana, I'm sure this is not new to you. We all appreciate that about 45% of all age mortalities are attributed to non-communicable diseases. And when we talk of all age mortalities, from the infants, maternal health care, road traffic accidents, all form of deaths in this country, close to half of them as a result of non-communicable diseases. And as a nation, we should be concerned. And that is the reason for which the Ghana Medical Trust Fund was established. Adding to that, once a diagnosis is made, it doesn't only affect the individual, but it extends to the family financially. So research has shown that within the first 5 years of diagnosis, many families will fall below the lines. So many families will fall below the lines of poverty, and we need to make serious investments in infrastructure and equipment to be able to raise our health facilities to levels that they can offer this specialized care to our patients. So the Ghana Medical Trust Fund was established as government's commitment to deal with this challenge that I've explained. So it was established in July this year by Act 1144, and it was established as government's commitment to tackle the financial burden that chronic non-communicable diseases offer, cost to families and cost to the patients. The diseases of interest for now are cancers, kidney failure, cardiovascular diseases, stroke, diabetes, hypertension. But then the Board of Trustees would outline the specific conditions, then we can work the benefits package and the tariffs accordingly and roll out. But once we are here for deliberation, we can have some discussions on that. Our mandate is to mobilize resources to provide specialized care for patients living with chronic non-communicable diseases. But this mandate can be broken down into 4 pillars. The first one has to do with the direct financial support, and this is a very common one that almost every Ghanaian is aware of, where the fund is stepping in to pay the medical bills of patients who have these chronic non-communicable diseases. But our mandate goes beyond that. It includes investments in infrastructure and equipment. And this is important because if you have to deal with specialized medical conditions where you want to offer specialized care, then you should have the human resource and you should have the equipment and infrastructure to be able to deliver that. So there is no point paying patient bills if they go to the hospital and that service is not even available. So you are not paying for anything essentially, and the patients are not getting anything. So it's important that we lift our facilities, the referral facilities, those that offer tertiary services, to a status that they can actually offer these services that you'll be paying for. So if a patient has cancer and needs radiotherapy and they go to the hospital, there's no radiotherapy machine, they don't have that service and there is nothing for you to even pay for. So it's important that you equip these facilities with the necessary tools that they will need to be able to offer the service, and then paying the medical bills will actually have a true meaning where patients can actually benefit. It's also important that we build capacity of our health professionals. Once you are offering specialized medical care, you need some specialists to deliver that service. Specialists, doctors, nurses, pharmacists. You need your biomedical engineers and technicians to be able to care for these machines, maintain them, service them so that we are able to enjoy the full benefits. So capacity building is also part of our mandate. The final one is medical research. Research is very important because it shapes policy. If you don't understand the risk factors, if you don't understand the demographic distribution, if you don't understand the pharmacodynamics of the medications you are going to use, it's even difficult to develop protocols that you use to treat these patients. So it's important that we invest in medical research so that the information we have takes into account our setting as Africans, the socioeconomic challenges, the geographical inequity, the genetic disparity, so that once we are developing policy, once we are developing our protocols, we know that this information we are using is information that actually reflects the true state of our health situation in the country. So the fund has this structure. First, we have legal status. Like I said, it was established by an Act of Parliament, Act 1144, and this means as a body operates to be able to acquire property, engage partners, go into contracts, and the rest. We are governed by a 13-member board of trustees that provides strategic oversight, policy direction, and resource management. And we have an administrative structure which is led by the administrator that runs the secretariat and sees the day-to-day activities of the fund. This is the composition of our board of trustees. So we have executive leadership where we have a chairperson and an administrator. We have government representatives, so we have directors from the Ministry of Health, Ministry of Finance, Ministry of Social Welfare. We also have the CEO of the National Health Insurance Authority. We have health sector experts where we have representatives from the health sector as well as the pharmaceutical industry. We also have a health professional who has more than 50 years experience in management of chronic diseases. We have a legal practitioner also with more than 10 years experience, and we have some nominees from the president. So this is the composition of the board of trustees. Because the vision is big, we will also need big money to run this. So for this year, we have a budget of about 3 billion, and this is the breakdown. We have the chunk of this is from a percentage from the National Health Insurance Levy, and we are required to also raise funds from strategic partnerships, from corporate Ghana, individual contributions, and donations. We're also supposed to raise money from investments that the fund would make, and also we get some money from parliamentary budgetary approvals. These are the factors that go into the disbursement of the funds. So first, we consider the disease burden analysis. We are looking at the cost of care and financial equity. So in treating condition A or condition B, what actually goes into that treatment? What's the cost of the consumables? one that's very cost effective. We're also looking at geographical equity. This is important so that we do not concentrate all the equipment, the infrastructure, the specialists at certain areas. Then we defeat the purpose of universal health coverage if people will still have to travel miles to access such services. So while we are dispersing these funds, we are looking at ensuring that the geographical equity, someone in between does not necessarily have to come to Tamale or Kumasi or Accra for radiation therapy. Someone doesn't have to travel 2 regions away just to be able to have a surgery or have dialysis. And this would help us in the disbursement principle. We're also looking at the health outcomes. What is the mortality? If you have a particular disease that the mortality rate is about, say, 70%, and another disease that has a mortality rate of probably 10%, and one is affecting 2 million Ghanaians, one is affecting just 100,000. We will look at these statistics, and that will help us decide which conditions we even roll on board, such that we have many Ghanaians actually feeling the impact, so that we do not treat diseases that are affecting just fewer people to the neglect of conditions that are affecting so many people and causing a lot of devastation. All of us as Ghanaians stand to benefit, directly or indirectly. We are all deeply connected to NCDs one way or another. It's either the individual has the condition, or a relative has the condition, a friend has the condition, an employee, a colleague at work has the condition. So one way or the other, we all have some connection to NCDs. So if this policy rolls out well, we all stand to benefit indirectly. Hospitals also benefit from the infrastructural and equipment investment that we're making. Health professionals will benefit from the capacity building that will come. People who are interested in research can also benefit from the grants. But the Ghanaian who benefit directly, first of all, must be Ghanaian, because this is a policy for Ghanaians. Secondly, the individuals have a condition that is actually covered by the fund. If you have a condition that does not fall within the fund, say you have a communicable disease, unfortunately, you may not benefit directly from the fund, and the individuals should also be registered under the National Health Insurance Scheme. This is the process by which individuals are able to access the fund. So first of all, there must be a consultation. I mean, you don't sit in your house, diagnose yourself, and apply for funds. There's no guarantee that you even go for the service, you go for treatment. So first of all, there must be a consultation. And the consultation, we emphasize that it must be with a specialist. Remember at the beginning, I pointed out that the Ghana Medical Trust Fund is focusing on specialized medical care. So because it's specialized medical care, the only guarantee we have that you'll be getting specialized medical care is that you have encountered a specialist. So the specialist does the consultation, arrives at the diagnosis. Another reason why this consultation is important is because, let's be honest, many patients do not know the details of their conditions, especially those who may not be enlightened academically. So they mention the conditions, they may not have so much details. So if you are taking applications from them, chances are that you may not get a true picture of the condition that the patient has. So first, you have a consultation with a specialist, a diagnosis is made, confirmed, provisional, but there's something to be working with. And your specialist puts in an application on your behalf. Once that is received, it will be reviewed by the grants and technical committee. Then a decision is communicated to the facility and the patient. That decision is either you've been accepted or it's been rejected. Like I said, it could be rejected if the patient doesn't meet the eligibility criteria, say it's not Ghanaian, or his condition doesn't fall under one of the conditions we are taking care of, then for that reason you could be denied. But once he's accepted, communication will be made, treatment will commence, and the hospital will be reimbursed based on the tariff structure that is agreed upon. The board of trustees would define the benefits package. In fact, first they will define the conditions that we are taking care of, but of course they will do this under the recommendation of the technical committee. Once they define the conditions, they will go ahead to do the benefits package and the costing. This will be communicated to all Ghanaians, will be communicated to all the stakeholders. NCD Alliance Ghana will be communicated to the health facilities, hospital managers, medical practitioners, will be communicated to the media, Ghanaians in general, so that we all know what exactly we are doing, which conditions fall under the fund, and how you can access it. Then evaluated every year. The purpose of this evaluation is that, the times change, our problems change, we get new data, we get new information. So this evaluation lets us add on more diseases. It lets us adjust the tariffs so that it reflects what's actually happening on the ground. So this yearly evaluation is very important to ensure that the benefits package, the diseases remains relevant as the years go by. We want to maintain quality. We want to make sure that what we are doing is of good quality. And to be able to do this, we'll be working with regulatory bodies. These are just a few of the regulatory bodies we'll be working with. EFRA, because they license facilities to be able to operate. They make sure that the facilities actually have what it takes to offer tertiary services. So they are very important. We're working with the medical and dental council to ensure that these specialists we are working with actually have gone through the right training and have the necessary certifications and licenses to practice. Also working with the pharmacy council, allied health professionals council, and NMC, that's the nursing and midwifery council, to ensure that the persons we are training, are they actually qualified nurses? Have they worked a number of years to qualify them to train? This is also important because once you are training, you need to bond them. You need to put in a mechanism to ensure that you are just not training people who at the end of the day would actually either leave the government service to go and do private business or even leave the country, like we have seen. So we have to have a mechanism to be able to bond such people, and this will be done when we are going to work with some of these councils. We will have a medicines list. While we have a service list which I've explained, the conditions, the benefits package, the tariffs, and all, we also have a medicines list. And this medicines list will include the medications that have been approved under the fund. There will be annual reviews to add, to reclassify, to take out some medications, and we also adjust the prices as the years go by to reflect what's actually happening on the ground. But there are exceptional cases where the board of trustees can approve new technologies, new medications when the need arises. And a classical example was the instance of COVID, where new vaccines were produced. This was a dire situation, new technologies had come. And we don't pay for such a situation, but in the event that we have such a situation where there's a need for the board to approve new technologies and new medications, even before the year ends, that will be done so that we can update the medicines list to meet the needs that we have at that time. The payment mechanisms we want to use, there's one that's fee for service, where you are paying for the services that has been offered in terms of the consumables that are being used. And there is the diagnosis related groups where the payments can be made broadly based on the diagnosis that has been made. So it's a round figure for the specific diagnosis, and that will include all the various steps, the various services, consumables, tests, medications that will come under it. And also we are open to other mechanisms that the board of trustees will determine and will approve for us to use as payment mechanisms. Because we'll be dealing with facilities, the payment plan will be based on the facilities, not necessarily individuals or based on health practitioners. So the service is delivered, claims are submitted, the claims are vetted, and payment is made. It's quite straightforward. You see your doctor, they apply, approval is given, treatment is done, claims are submitted, claims are vetted, and claims are paid back. In the event that there's rejection of the claims for whatever reason, the hospital will be communicated to, or the facility will be communicated to, and they are allowed to resubmit. That's usually the reason for rejection is clerical, and it's something that can be fixed. So they are allowed, they are given the opportunity to rectify whatever errors it is and submit again for consideration. The Ghana Medical Trust Fund has been in operation for, the Secretariat has been in operation for barely 10 weeks. And in the 10 weeks, we have been doing some work which I would like to share with you so that you understand the progress we have made so far. And this can guide some of our discussions. So first, we have a secretariat, an office in Cantonment that is operational now. It was commissioned some weeks ago. We also have a board of trustees that has also been inaugurated. I think this is about their 4th week since they were inaugurated, and they've had a number of meetings to make sure that we operationalize very well and the Ghanaian can benefit from what the Ghana Medical Trust Fund has actually come to offer. We're engaging in strategic partnerships my administrator rightly mentioned that we cannot do this on our own. And it's important that we collaborate with all the necessary stakeholders, civil societies, corporate Ghana, and all people who have a vision that aligns with ours. So we have been engaging local and international partners. This is an example of one of our international partners, and that's Mercy Ships. They have a number of ships that they've converted into hospitals, and they'll be engaged in an 11-month mission from next year where they will dock at our shores and they will offer free surgeries in a number of conditions for our patients. They will bring in their medical professionals, they will team up with some of our medical professionals, they will transport people from across the country to where the ships are, accommodate them, do the surgeries, observe them post-surgery, and they are sent back to their various communities. And this will go on for 11 months. So this is one of the projects we are working towards next year. We also partnered with Telecell Foundation to install some cervical cancer screening equipment. State of the art was done in Kolebu, another was done in Tamale, and one in the Western region. So this will help us to screen women for cervical cancer. The data we are getting on cervical cancer is that most women present in the late stages. I think if you understand the anatomy, where it is located, it's not something you see every day. So by the time they notice changes, it may be too late, and very little can be done for them. But once you have machines where there's regular screening, then it helps. Because any changes you see, you can pick it up very early, and treatment can be done to improve the outcome, to improve the outcomes. There's also a program by the Ministry of Health that has to do with vaccination. So we are not working in isolation, we are working with all the necessary agencies with libraries to ensure that we are able to improve our country as far as non-communicable diseases are concerned. So this is one of the partnerships that we are engaged in the few weeks that we have been in existence. We are also mobilizing support, which is part of our main mandate to raise funds to finance the provision of specialized care for chronic non-communicable diseases. So we have been inviting a lot of institutions, corporate Ghana, a lot of state-owned agencies. We have been visiting them at their offices, sending letters, having meetings, presentations to them. And some are actually coming through for us, which we appreciate greatly. And we still extend a hand of partnership. People have come to donate into the fund, and I'm sure this will go a long way to be able to help patients with chronic non-communicable diseases. We embarked on a needs assessment tour in all the regional and teaching hospitals in the country. We chose the regional and teaching hospitals in the country because these are the hospitals that offer tertiary healthcare. Of course, we know there are some few hospitals which do not have the designation of a regional hospital and teaching hospital that also offer some form of tertiary service, but we must start from somewhere. So we are starting with the regional hospitals and teaching hospitals. The main reason is that the complications of these non-communicable diseases by protocol are supposed to be referred up the ladder, so from primary healthcare to secondary to tertiary. So when the kids compound or the district hospital sees a cancer case and they refer to a teaching hospital like Tamale, does Tamale have the capacity to actually deal with this condition? Because if the teaching hospital cannot deal with it, then where else are they going on our ladder? Because aside the tertiary hospital, we have the quaternary one, and I think we have just one, that's UTMC. So if our tertiary hospitals do not have that capacity to be able to handle these conditions, then we are now going to overburden UTMC, and people will now have the option of traveling abroad, which escalates the cost of care. So we want to make sure that our regional hospitals, our teaching hospitals, when these referrals come, they actually have equipment, they have infrastructure, they have facilities, they have specialists to be able to handle these conditions, and this is why we went round. So we went round to understand the real-time challenges in terms of infrastructure and equipment, and also understand the service delivery gaps. If a patient comes here, why can't we have dialysis? Is it because we don't have the machines? Is it because we don't have a nephrologist? We wanted to find out all these challenges to see how we can develop our policy and our interventions, which are very relevant and specific to each of the hospitals. And that is why we started this needs assessment tool. We are happy to inform you that we have visited all the teaching hospitals. We have visited the regional hospitals with the exception of one, which will be completed before the week ends. And once we are done with that, we have a comprehensive report on all these hospitals, which we can submit to stakeholders that are interested in partnering with us to be able to make sure that we supply these hospitals and retool them to a level that we can deal with the cancers, deal with the strokes, deal with the kidney conditions, the complications of hypertension and diabetes that Hospital, Sunyane Teaching Hospital, all across the country. Like I mentioned, it is very important that we retool these hospitals. If these hospitals are not retooled, it's difficult to pay for the medical expenses. There was a situation in Provence, which a lot of you may have heard, where a medical practitioner needed an urgent service. They had the funds, but the facility was not available. So it's not just about the funds being available. Once it's affordable, it's a good thing. But affordability must go with access. If it's affordable and the access is not there, that affordability doesn't mean much. So in that case, they had to airlift the patient to Accra, and by the time he got to Accra, he passed. It wasn't an affordability issue, it was an issue of access. So while we are trying to make it affordable, it's important that the services must be accessible. And that is why we want to engage in this hospital retooling. Because, for example, with radiotherapy machines, the whole of the north doesn't have one. So all the cancer cases in Upper West, Upper East, Savannah, Northeast, Northern Region, OT, Bono East, Bono Ahafo, they all have to come to Kumasi. And sometimes once we give the referral, if they don't have a relative in Kumasi, they might as well not come. Because it's not a one-time treatment. It's not something you go, you do it in 2 days and you return. It's something you do in weeks. So once you don't have accommodation, the cost of accommodation becomes included in your cost of care. You have to go with someone because the person is sick. You don't go alone. You have to go with one or two relatives to care for him. So this escalates the cost. So access is very important, and that's why we need to embark on this hospital retooling initiative. So we are happy that this stakeholder engagement is happening. We are happy that all of you have some connection to NCDs, directly or indirectly. We are happy that most of you have some expertise in health financing and the management of chronic non-communicable diseases. And we are happy to hear from you. We are happy to discuss the questions you have, offer clarity where it's necessary, take your opinions to see how we can shape this, make sure that in our operationalization we are able to capture some of the inputs that you share and fine-tune this policy so that it's actually beneficial to all Ghanaians. Thank you very much.
Thank you very much for that detailed and enlightening presentation. God bless you. And now I'll open the floor for questions. Before Madam's ended her speech, she said, and I quote, we ask you all to ask questions, bring your plans and your ideas so that we all share. So this is the time. We are here. Any question at all, let's bring it on board for them too. Like I said, if you need anything, call me. I'll come to you.
Thank you very much. My name is Solomon. I'm from Fast Ghana, and let me see. Let me add a little more. Yeah, because the question I want to ask relates to the layman. Doc, thank you so much. If you've been able to do all this in 10 months, so what are you going to do next year? Yeah.
10 months?
Yeah.
10 weeks.
Oh, okay, 10 weeks, sorry. Anyway, so Doc, this is my second time meeting. But congratulations once again for the good work you are doing. I'm the senior brother of my mate, Moridogo. You're not from. Yeah. So, my first one is, does it mean that the implementation has not started despite the fund allocations? And then, how do we ensure that those who need this are delivered timely? Because from education, let's take the scholarship scheme for instance. Those who need it don't get it, but the big people who already have the money are those who are benefiting. We hope this is not going to be a repeated situation. And then your colleague did a nice presentation, but I'm wondering how many Ghanaians are aware of all this. You know, so do you have any plans to take the campaign, the awareness to the grassroots? Because there are the people who miss it. Today you may not have the NCD, but tomorrow is not guaranteed. Anybody but especially to the hard to reach communities to ensure that we understand the needs and the dynamics of the trust fund so that we can access it. Thank you very much.
Let me ask my question. Okay, please, during your presentation, you said the fund will come in for the primary stage when they cannot afford the fund will come. I want to ask, because some people from the early stage or the primary stage, they can't even afford to pay all these things. So must I sit down and wait till I get to that stage where I can't access it? So we take like 5% and you come in.
Yeah, okay. I had two questions. She's asked one, but I want to add to her question, which is, if an old woman in a village suffers from stroke or levels sudden, and she's not able to even move to the facility and even get the assessment before applying for the fund, at that initial point, what happens to her? Then my other question has to do with when an application is rejected. You may mention in the presentation that the person will have the opportunity of reapplying. That's based on the reasons for the rejection. My question is, if I get rejected and I reapply, rejected, what happens? Do I use? Is there an authority that I can apply or report or go and get help from, and other that the fund will come to my aid, or if your application is get rejected repeatedly, you just go home and die.
So let me just ask two more questions. This is a beautiful initiative by the government, and I'm very excited as I sit here and I listen to the presentation from our brother. For some of the works in the health NGO, we really know what this fund will be for our beneficiaries out there. But I have two questions, like I said. The first one has to do with a specialist medical practitioner doing the application on behalf of the beneficiary. I'm just wondering, would it's also become a barrier for beneficiaries knowing what already exists in the country? If the professional has to give you some recommendation or apply for you, won't it become an avenue for sourcing money from beneficiaries, so that if you don't pay this amount of money, I'm not going to apply, do the application for you? That is one thing that I wish we could look at carefully. And then the other thing is sustainability beyond the election period, beyond the government, the current government. Are we able to guarantee that this fund will not be to migrant children, children? Yeah, this are the two. Okay, so thank you.
Thank you very much for all the questions. So the first question, I'll try my best to address all the questions as I do. In case I missed anything, I just draw my attention. The first one has to do with the commencement of implementation. So our mandate is a fourfold. Like I said, there is one that is very popular, that everyone is interested in, which is the direct financial support. Aside that, there are other three pillars that we're working on. So if we talk of the commencement of implementation, it has actually started on some of the other pillars. Like I mentioned, we have visited facilities that do needs assessment. We have had engagements with some of the training institutions that train specialists. We have had agreements with them, marked out a plan for training specialists for the coming year, that has been done already. We are meeting companies on retooling. We are meeting institutions that are partnering with us to be able to procure some of these equipment. So as far as that is concerned, implementation has started. When it comes to the direct financial support, that is where a lot of work has to go into. Because like I said, you first have to determine the diseases that you take care of. You have to draw benefits package. So, for example, when it comes to say prostate cancer, what exactly are we doing for prostate cancer? Are we paying for biopsies? Are we paying for imaging? Are we paying for medication? Are we paying for the surgery? Medications are we paying for? So a lot of work has to go into that area. And that is still ongoing. So until that is done, we cannot roll out, because then once you even apply, you don't even have a criteria to know whether you qualify or you don't even qualify. And if you qualify, how much are you giving? You are giving 2 seats or are you giving 20 seats? So all the details must be put together before we can roll that out. So for that particular one, work is still ongoing, but on the other pillars of our mandate, implementation has started. The second one has to do with how the council will decide that those who need it actually get it. So this will come in 2 forms. First, the diseases will be determined, costing will be done, tariffs will be assigned for each service or each medication that will be used for the treatment of these conditions. And then it is general. So we mustn't give no room to enjoy it. Once you have that disease, there is costing that is done, there are tariffs assigned to get to the hospital, they are treated for it, reimbursements are made. So the fund will not even know. I don't know if you understand that. On the second component, which has to do with exceptions to those diseases. So for example, just say next year we start with, say, disease A and B. And someone has disease C, which was not even captured in A and B. Costing has not been done. But it is a peculiar case. Application can be made. So for those who have the A and B, we mustn't even know you have treated, claims are submitted, payments made back. But the person whose disease does not fall under what we are doing, and for some reason still needs help, that's when that application can be made. And once that is reviewed and the patient meets the criteria, communication will be made back to treat and reimbursement will be made for that special case which does not fall under the general one that will be made. I don't know if this is clear now. And I want to use this to tie into another question that was asked about specialists making applications and whether that can lead to corruption. Yeah, so the first thing is that, I mean, in our time, we have received applications. Once you see the application from a specialist, you see the work of the patient, you see the difference. The specialist tells you we are managing the patient for this condition. This is the exact procedure we want to do. This is how much it costs. It will take us this number of days or weeks to treat. We would work with specialists from this other department and this other department. There's a lot of clarity. But once you take it from the patient, I can give you an example. The patient brings a report, says I have kidney infection. So once an infection is communicable, it doesn't fall on us. So immediately, I wanted to dismiss it, but I said, let me follow up from the hospital. I follow up and I find out that it's not an infection, it's something else. And this patient would have qualified if that disease was captured. But the way the patient presented it, he presented it as a communicable disease, which on the face of it would have been put aside. So once we are taking it from the patient, we don't get so much detail, we don't get clarity. And like I said, patients may not know the exact conditions they have. He will tell you something else. The patient cannot tell you what procedure we have to do. The patient cannot tell you exactly how much it will cost. So that's why it's important for us to get it. And getting it from the specialist also lets us know that the patient has even gone to the hospital and it's not fraudulent. It lets us know which hospital we are dealing with, who we can pay the claims to. Because the direct support is not to the patient. It's not that because you have this condition it will cost 10,000, we give you 10,000 as an individual. You go to the hospital, the service is given, and the hospital is paid for that cost of service. So that's why it's important for you to come through the hospital system, so that we know who exactly we are dealing with. We are sure that you are getting specialized care, and we can deal with the issue of fraud. I mean, on the issue of corruption, it will take all of us to have integrity for some of these things to work. And it's not only in our health space. Anytime there's a system, the system will thrive based on the integrity of the people who are supposed to run the system. So we can't take away the fact that you have one or two people who want to take advantage of it. That is very true. But then our contacts are available. You can always report that if I've gone to this hospital, I want them to make an application for me, but they are demanding X, Y, Z.
and then we can take it up from there. But we are not hoping that our health professionals will do that. But in the event that they do, feel free to the secretariat and we'll deal with it at that level. The third question has to do with advocacy and publicity. So this is very important because stakeholder engagements are important because we all get input from you. And it's also very important because everyone then feels as though they own the project. They feel like this is a project that I was part of. So aside the stakeholders themselves, the regular Ghanaian needs to know because they will be the direct beneficiaries. So we have mapped out a plan for massive advocacy, massive publicity, and this will come from our corporate communications and stakeholder engagement departments. We have a well-structured plan where we engage in media, electronic, social media, print, reaching out to the communities, liaising with the district and the district and regional health directories to get the message across. So this is something we are working on, and we are sure that once we are done with that massive advocacy and stakeholder engagement, a lot of Ghanaians, if they don't even have the full idea, at least they would have heard of Mahama Cares, and at the very least, they will know how they can access it. There was a question about waiting till it gets bad before you seek help. This current government has two flagship programs in health, and that is one is the Ghana Medical Trust Fund, and the second one is the free primary health care policy. So the free primary health care policy actually starts from the primary level. So in our health system, there's a primary level that deals with prevention and basic care. So that's the CHIPS compounds, the polyclinics, hospitals. Then once they have capacity to be able to deal with certain conditions, the conditions that are above them, the law or the protocol demands that they refer to a higher hospital, which will have more equipment, more human resources to be able to handle that. That's the secondary level. Protocol also demands that after, if those people are not able to handle either as a result of equipment or capacity in terms of human resources, then they move it to the tertiary level. So we are not saying that you jump from your house straight to MahamaCares. You should have gone through the system. There are protocols. You can't just walk and see a specialist. I hope we are aware. You can't just wake up and go and see a specialist. That's not how it works. You should have gone to a family physician or a general practitioner. Then he determines that this condition you have, this is the best specialist for you. Then he gives you a referral to go there. So we're expecting that before a patient has a cancer and is seen an oncologist, it must have been diagnosed from somewhere because he has certain symptoms and went to either the polyclinic or the district hospital or something, the CHIPS compound, and the referrals were made, diagnostic procedures were undertaken to go to the level of the oncologist. So you don't just wait. And because it's a free primary health care policy, that will be taken care of free of charge. Even this policy, you don't need to be registered on the National Health Insurance Scheme before you enjoy free primary health care. So after the free primary health care, then the National Health Insurance deals with majority of the conditions. Then where the National Health Insurance ends, your condition is very expensive. National Health Insurance ends to some level. Then MahamaCares comes in. So it's a three-tiered system. You don't just jump from one point to the other. You go through the system. At the very base, it's free. At the National Health Insurance Scheme, it costs averagely about 20 to 30 cedis to renew yearly. They would take care of a lot of conditions. And where they end, where they are not able to continue in terms of reimbursement or paying for certain services, then the MahamaCares come. So you just don't sit at home and wait. There are other avenues by which you can be taken care of free of charge under the health insurance. Then it can come to the Ghana Medical Trust Fund. On the issue of application rejection, actually it was claims rejection. So once the hospital submits the claims, obviously we will, as I mentioned, sometimes it could be fraudulent issues, sometimes it could be just clerical, maybe they didn't input the data well, so it didn't come out well. It could be rejected. For whatever reason it's rejected, that hospital has the opportunity to correct what the problem is and submit it in. So when the rejection is, of course, will be communicated to us why it was rejected, and that can be. So that rejection was with respect to claims and not applications. But once the individual applies and is rejected, reason will be given for the rejection. Like I mentioned, one has to do with your disease, whether it's fallen under the Ghana Medical Trust Fund in the first place. Two, the Ghana Medical Trust Fund does not fund treatment outside the country. So if you are bringing that you want to go into a surgery in India, automatically you are out. It will not cater for, say, cosmetic surgery. I don't know if you understand. So if you are rejected on that basis, I don't know what correction you are waiting for. Unless, of course, maybe you are supposed to have the treatment in India and you've been rejected, and now you want to see a Ghanaian doctor and it can be done in Ghana, and you can apply it. Yes, so that's it. So that rejection was restricted to not necessarily the application.
So your decision is always final. Whatever the jury decide in the end, that is an applicant or the facility can go beyond you to report to the other authority. Yeah.
Okay, all right. So, I mean, like I said, this is a stakeholders engagement. I appreciate the fact that individuals may not be satisfied in the event that there are rejections. What would guide the acceptance or the rejection of an application is that by law. So first of all, we have an act. So this preliminary things that is based on the law. Like I said, fine details to come. But on the basis of the law, if it's communicable, it's out. I don't know how that can be appealed unless we want an amendment in the act. If it's treatment outside the country, the act is very clear that will not be taken care of. So that is out. I don't know how an appeal can be made. But I also appreciate the fact that individuals may not be happy, may have issues with it, and there will be a need for them to appeal. So I think that will be taken into consideration. That can be passed to the technical committee. They can consider ways like which individuals can apply either to the Ministry of Health or whatever. That fine bill can be worked out. But I appreciate the skill will be factored. So there was a last question I wanted to address before administrator also addresses. And it should have to do with sustainability beyond
I think that very often we get this sustainability questions, and I think that a lot more people get scared, especially when they hear MahamaCares. So everybody is thinking that after Mahama, what happens? Please, let's take note that in the Act, it is called the Ghana Medical Trust Fund. MahamaCares is just a nickname. You understand me? So let us not think that the moment this government is no more, this fund will collapse. No, it cannot collapse because this is one of the well thought through visions of this government. And I'm sure that for those of you who know how national health insurance started, you know that we are on course. And I'm sure that in the next 4 years, you will see what the Ghana Medical Trust Fund can do so far as our nation is concerned. So let us not be too tied up about what will happen after Mahama. The Ghana Medical Trust Fund is here to stay. And let me also tell you that we've started working on a document for the Ministry of Finance that instead of even taking the COVID levy out completely, because the finance minister is ready to go and cancel it, we are advocating that it should be called the survival levy, because if that levy is given to the Ghana Medical Trust Fund and then we have a reliable financing medium, I'm telling you, what we can do so far as our specialist hospitals are concerned will be mind-blowing. So all we need is what we have started with, 20% from the Ghana, from the National Health Insurance, government's own seed money to us, corporate institutions are responding to us, and we are so overwhelmed. Maybe some of them are the ones who are even calling us, because you know most of them have their CSR budgets. Now most of them are thinking that, listen, instead of doing ABCD, maybe we can partner with the Ghana Medical Trust Fund to buy an equipment or two for these specialized hospitals. So I think that as the advocacy that we are doing and telling them that it's a good idea to partner us so that we can do these medical establishments equipment, retooling and all is good. And most of them didn't know about this, but as we take the conversations into their conference rooms, their board rooms, they are all getting excited about it and coming in to help us. Let me give you an example, and I'm sure that you'll all be wowed. If you walk into the Ridge Hospital today, the Ridge Hospital sees about 800 plus patients a day, not a week, a day. But the Ridge Hospital cannot boast of even a mammogram machine. It does not have a CT scan. It does not have an MRI, not to talk about X-ray machines. So for the equipment side of that hospital, they are down to zero. So you and I will go there, and then by the time the doctor gives you that treat to go and get a test done, you have to walk out of that facility to go and get it done before you bring your report to the doctor to give you medication or onward treatment. And we sit here and we say that the Ridge Hospital is our regional hospital and this is our capital city. We should be worried. And that's why I say that what we saw on our needs assessment tour is devastating. And I'm happy that we didn't just get this appointment and sit in Accra and make decisions. I'm happy that we went to the ground to understand the situations in our various facilities. And between you and I, there's nothing to write home about. We need to applaud these doctors and all these persons who work in these facilities. They are being stretched and they are doing their best. If you go to a Fiakwanta hospital, when you finish, you sit in your car and cry. I finished and I lost my appetite. I'm just thinking, this the facility that we call a teaching hospital, a regional hospital, and look at these Galamsey issues and all the issues in their surrounding regions, they all transfer and repair them into that facility. Meanwhile, if you have does not even have a mammogram machine. So, what are we doing to ourselves? I think that if there's anything we need to advocate for, we need to advocate for us to get direct funding so that we can use it to retool these hospitals, let them be able to treat these patients, pay their medical bills, and I'm sure that is one of the major problems that this country faces. It could be you, it could be your mother, it could be your father, it could be somebody in your family. You don't know when one ailment will hit you. But I'm telling you, if we start the discussions here today and take it out there, we can make a difference. Thank you very much.
So, just to add on to previous comments, to let us know that we all need to support this process. Now, the Constitution guarantees that we have health as a fundamental human right, but you realize that actualizing this challenge, sometimes we don't really have for it, for the resources are limited. So in an era where we have gotten innovative financing with domestic level, I think it's something we need to commit very seriously and support. First of all, the capping of any child, very innovative approach that's going to free funding for development of our healthcare, so that the basic needs we have as a country in terms of our health will be catered for. In fact, health is actually the wealth of the nation. What is the threat of productivity as well published? And if we have a funding mechanism that enables us to be able to pick these things early in the form of the family health care, free family care, and which is also replacing the existing NHI. The existing NHI covers about 95% of our disease conditions. And we have still about 5% to be covered. So, the mechanism that will enable us to cover the other, and I think very innovative. We are witness to what happened when people pushed on dialysis. We just did last year. And people, the average annual processes It goes to averaging 300, 400 per session, 3 times a week, the whole of its life. And it will have, as Peter said, we just not look at statistics, but we are looking at lives. So I think it's something we must all embrace and support fully. And I think if I were a corporate director and I have to spend huge money to pay for audit conditions of my staff, I rather enroll them onto this, register them under the MahamaCares, and ensure that it's taken care of to this level. Because the cost of managing all this for staff in the certain companies is huge. So I think it's the dawn of good life, good grace that we all need to be excited about, knowing that as an average Ghanaian, I don't need to be afraid. I can have the peace of mind to work for my mother country. And there are systems to prevent me getting disease conditions in the form of the private health care. When it advances, the regular data will come in. And when it goes beyond that, I believe society has put in place something that will nurse my pain, that will help me recover. And in the event that I'm very able to recover, the simple palliative care that I will get before I leave the deeper is something we must commit before. So I think it's something we must embrace as a society going forward. The issue of sustainability, I think all political parties are one on the issue of the healthcare of Ghanaians. That's what I know. And I'm aware that this has passed through Parliament, which means that there's a bipartisan support for it, and it is united by law. So going forward, I think the policy state, the next school will take it very strongly on our policy lines and ensure that this is done. So let's embrace it, let's be excited about this. I would want for the president and the asked to also that the ministry is open for federal partnership also. That's what we have done for our case. Also open up for discussions of the free private healthcare to better appreciate the activities. Whatever we also need to do, especially the media, to support the transfer to the secretariat to share these very ideas with the entire general population. I think we need to do that and give them those opportunities in terms of the corporate social responsibilities, give them a platform to be able to share these ideas. And I'm sure together we will advance as a country. Congress, and well done to the transfer of the decision for what we could start. And I think the feedback you will be getting from the school parents that as to those other disease conditions that are not in country, the whole fund is also open for quality improvement. They said there will be annual review as was presented. And when the Ghanaian population, that is the owners of this country, that is citizens, say this is what we want, and they stand for it, the government will listen. The government is actually us, and we have the power. Yes, we will see very certain arms of government to exercise. So if we take it and we set the agenda, government will listen, ministry will take up the policy and ensure that what we overlooked will be considered on board. Thank you very much.
All right. Good morning, and thank you for the opportunity to ask these questions. So my first question is, when someone makes an application, how long would it take for them to get a response? The rumor floating around is it's going to take 2 weeks. Could you confirm or deny that? And then related to that question, if there's an emergency, for example, someone has an allergic stroke and a procedure needs to be done immediately, if it's going to take more than 1 week for approval to come, can the person get that procedure done and then the approval comes later, or what's your thinking around that? And then the one who applies have to demonstrate financial need, because there may be some people who can actually fund their own treatment, but they still want to access this. If because they're still Ghanaians, they may be ineligible. So if that can happen, would you be considering maybe open a structure where for those who are able, they can also fund part of it and Mahama transfer to it so that we protect the money, the funds that we have in MahamaCares. And then, sorry, Elizabeth, the next question that I have has to do with the diagnosis of the kidney care. Earlier this year, the World Health Assembly adopted a resolution to promote kidney transplant as a preferred mode of renal replacement therapy. And if you think about it, for someone who requires dialysis, they are going to require it for the rest of their lives. But when that person also gets a kidney transplant, that is most often once or so when you compare the impact on their budget, it might be better to promote the kidney transplant than dialysis. I want to know if this is something that the fund is thinking about. And then my last contribution has to do with stroke care. So Ghana's stroke care is years behind. I mean, stroke is the number one killer in Ghana. If anyone here is going to go by statistically, it's going to be unfortunately. But when it comes to the stroke in Ghana, we are so behind. From probabilities that you need to machines that you need to do the progression. So I was so happy when I saw that in the start. And you may not have this answer now, but I just wanted to know what is probably going to go into this. Since when you check the statistics, it's always number one. Thank you.
So thank you very much. I think my colleague has really taken the seal from the beginning. Yes, so my name is Ad Adams, the Executive Director for Stroke Association Support in Ghana, also the Vice Chair for the Ghana NCP Alliance. I'm a rehab professional, specializing associated with, of course, post-discharge rehabilitation for persons living with stroke. So I was actually more happy when you mentioned the issue of course treatment of acute treatment of stroke, because we do understand that of course the policy or the initiative actually captures treatment of stroke. And I was so much happy when you actually embark on this assessment. One area that of course I have engaged with some of the experts, including experts working in the area of neurology, Professor Albert Akalu, cardiology, and the rest, is the issues of access to timely diagnosis. So when issues like CT scans, MRI, of course, ECT for detecting heart diseases and stroke were mentioned, I was very particularly happy because it has been on the forefront how this issue can be managed. The best way to avoid people traveling outside to have these devices here in Ghana, because we don't have them. That's why they travel outside. And then aside that, I also saw on your core page that, of course, there is something like missing awareness rate. You know, you are talking about training, training of professionals, of course, innovation, investment, and like that. Now, for how to look at preventing and treatment of the disease, we should also look at prevention. But that is not mentioned, captured under your core page. In other words, you have an issue whereby we look at treating, you'll be treating, and more numbers will be added to it. More numbers will be treating it. So that is an area that I want you to address. And lastly, got to do with our post-discharge. Now, most stroke patients are not able to afford the cost of sessions for rehabilitation. That is a major challenge. It's rather unfortunate we didn't have some of the stroke survivors with us. They could have shared their lived experience. The sort of charges and payment that we pay. You know, most of them are even having second stroke is dead. So I'm wondering if you can look at it in a broader way, how these issues can be addressed. Post-discharge, community rehabilitation, and of course I must say this, that we submitted proposals to the ministry for the National Policy is going to assist the technology and fabrication, which is still in the working. So I want you to the secretary to consider all this. Not of course it can be a lot of connection, you know, the continuum of care that it ends with person living with NCD. So if you take one out, it will be like we reinvent, they'll go back, they're still counting more days. So thank you very much.
Thank you. Okay, thank you very much. My name is Dr. Olivia Mwapwasi. I'm from Food and Drugs Authority. I'm actually representing my CEO, Professor Philip Manso. I'm glad to be here, but it's because I'm in another engagement. And my must admit that this is a very thorough job that you, Madam, and your team have done. And then he had actually said, I should tell you that we are committed to supporting this because public health and safety is our mandate. And this, every Ghanaian is interested in. All of us could be sick one day, and we should ensure that this survives. Mine is actually not a question, it's a comment. I realize that you have engaged a lot of the regulatory agencies for practice issue, but not for products. There was Pharmacy Council, HEFRA, and we actually are the custodians of the products, the medical products, the devices. We have a system, pharmacovigilance system that will monitor treatment schedules, side effects profile. So you really should engage us. If you don't come, we'll come ourselves.
So good morning once again. My name is Wally. So I think mine is not really a question. I don't work at the medical trust fund, but I want to say something that I think we should don't let them fight. I mentioned my name, yes.
We are having a very useful discussion, but I did, yes. We please, I did. Go ahead, don't get me, but I did. Dr. Quinn, let us know you. I want to know you better. The rules are special. Well, it's yes. So the medical trust fund is here to solve some specific issues. We already have the NHI. It's doing something. So I think it's going to line where the NHI can be empowered to do more, and then to leave the medical trust fund to do the things that will actually make sure that we achieve MHC. That's what I want to see. Because if you don't take it, will allow them to buy more than they can achieve. So I think that will guide us in that discussion. That's what I would say.
All right, thank you very much. My name is Isaac, a member of the NCD Alliance, and also with the Ghana Coalition of NGOs in Health. I work for my questions are very short. First is the 3 billion. This is fundraising daily, because civil society can help you reach that. So when you say 3 billion Ghana cedis, if I'm communicating to my Saudi Arabia, how much is it in dollars? And if I have a partner in UK, how much is it in pounds? And so then the next is what strategies do you have in place for civil society to partner with you? Because this is a civil society forum. How do we partner with you in terms of research, in terms of training, and in terms of funding? What mechanism do you have in place so that when we leave here, our minds are clear that we can come to you and partner collectively in a proposal writing, and this is the modality. Thank you very much.
Thank you so much. My name is Christopher. We're now with the Ghana NCD Alliance. I want to say that for a person that will NCD, any intervention when it comes to the health is welcome. However, I want to say that from the discussions we've had in the past till now, it looks like there's been a gap when it comes to engaging the persons who live with the conditions themselves. From your presentation, there seems to be a lot of leaning towards specialists. I hear a lot of specialists in heavily leaning on that, and then I'm asking myself, the persons who are living with the conditions themselves, what was the mechanism to engage them? Even the week in which the bill was passed, or this trust fund was passed, there was an engagement management party, there was a big gap in terms of engaging persons living with the conditions. And it is going to unfortunately bring a lot of issues because when I was listening to your tier, from the primary care to the NHIA to the trust fund, my issue is that even now as we speak, and there are a lot of persons living with NCDs, we can attest to the fact that our conditions are not completely covered by the NHIA. I have stopped using, and Laura is my witness, he has read on me. I stopped using my NHIA before, and it has been out of pocket. I've been paying for my conditions. I got my diagnosis 9 years after the first sentence. So what then are we doing to ensure that persons living with the conditions are actually the focal point of engagement? I have had my issues with specialists. It's not always rosy when you go and sit in the hospital room and have a discussion with the doctor, especially. It doesn't go completely like you would expect it to go. Sometimes they can kick you out. So what are we then doing? My other question is, for somebody that has gone through the process, let's say 10 years in, 15 years in, because NCDs are lifelong. Somebody who is in the condition does not have to go through a re-evaluation of their condition with a new specialist before accessing the care, or that person can then continue from where they are. Because I'm 15 years in, sorry, I'm 18, 19 years in. Do I go through re-evaluation before I access MahamaCare, or I have to bring my, because I have documents in Kolebu, in about 4 or 5 hospitals, and then now in Akai House. What then do I do? I have so many questions. But in as much as I acknowledge the fact that I have to say that gap of engaging persons with NCDs is completely chaotic for me. Thank you.
Thank you so much.
Once you are here, let them answer the question.
So I'll attempt to answer the questions that I have. Again, if I didn't get the question clearly, we will have some clarity. So the first one has to do with the application response. Yes. So yes. Then yes, 2 weeks. However, there's an exemption for conditions whose treatment are time sensitive, like strokes, like myocardial infarctions, and the like. Those that require time sensitive interventions. There will be exemptions for those ones, such that treatment can be made. We can backtrack that so you treat before you go through the process, because like you said, by the time you even send in an application, you have to do within 6 hours. So intervention you have to do within 6 hours. You don't have the time to send in an application. So the exemptions will be made for such conditions. So the application process, the reason why we have the application process has to do with the chronicity of the illness. These are not one-time treatments. So for example, a patient has diabetes. You will go for reviews, you will go for medications, constant labs. If there are complications, it's a treatment that will happen for a very long time, most times, lifelong. So that's why it's important that you apply and the treatment continues. But for treatments or interventions that are one-time interventions, like in the case of an intervention for a stroke, an intervention for an MI, it's a one-time intervention. The chronic management that follows thereafter is what you can apply for. I don't know if you agree. That's where the emphasis of the application comes in, because then we have you on our registry that so and so is being managed for this condition. And we know that for this condition, you go for review maybe every 2 or 3 months. That's determined by practitioner. You be on medications for a very long time. You have labs intermittently. So we have that on our registry. But for the one-time treatments that are time sensitive, you make the exemptions for that treat, then you can now apply. You know that so and so had a myocardial infarction this time, and you will be on prophylactic treatment to prevent another condition. So We have that on our registry. So it also helps in our data. Yes, will be a retrospective. Yes, a payment to cover the retrospective treatment. So then we have you on our registry to help also in our data collection and our analysis. Yes, then there was a question for patients that can actually afford it. So, no matter how rich you are, once you have a chronic illness, at some point in time you feel it in your pocket. If you have a cancer that you have to take medication, which is 10,000 cedis every month, and go for radiotherapy, which is about 45,000 session, you understand that no matter how rich you are, you feel it. And our bill doesn't allow to discriminate on the basis of the patient's financial standing. So if the patient can afford it, and the patient meets the criteria, there are patients who can afford it and do not even want to apply. I can pay for my cancer treatment, there's no point applying, just pay and they go. Some people go to a private facility and have that. But once the patient wants to apply, there's good reason for wanting to apply, and our bill doesn't allow us to discriminate in terms of location and financial strength. So once the patient can afford it, it still qualifies. As long as it meets the other criteria, the person qualifies to enjoy the service. On the issue of transplant, it's very important when it comes to renal replacement therapy. Actually, that's the gold standard. But not everyone can have a transplant, even if they can afford it. Sometimes the condition is so bad in terms of age, in terms of getting the donor, and the rest compatibility and all. So even if you can afford it, for some people, due to certain reasons, they will still have to be on dialysis. Again, even if they can afford it, they have a donor. They will be on dialysis for some time, stabilize them for the surgery. So dialysis, even though we have a gold standard of wanting a transplant, we cannot do away with dialysis. From the issue of affordability and the other logistical and technical issues that will surround having a transplant. Unfortunately, as a nation, the last time I checked, we didn't have legislation on transplant. Donor harvesting and transplant and all. So we have to start the conversation from that. I'm happy that it came up as one of the discussions in Parliament. We want to push for that legislation, and that is the only way it can open up for us to even have that discussion on whether MahamaCares will take up transplant. So once we have that legislation in place, we have a proper system for donations, so that we don't have people operating through the black market and increases the rate of kidnapping and all. Once we have a proper system where people can donate, we have a proper system where people who require the organs can be matched onto donors. Then we have centers that are established for such procedures. We have specialists that are trained to be able to carry that out. Then we can have that. But until this legislation is passed, until we put all these systems in place, our go-to is still dialysis, except for those who can afford to travel abroad. So that is why it's important that we should still have a system that supports patients for dialysis. We have enough centers to increase access, strengthen the health insurance to continue to do the good work like doing the reimbursement for the payments of dialysis, while we work on getting the definitive management, which is the kidney transplant. So that's something we are looking at, but we have to start the conversation for Parliament and the legal framework. Stroke care. I was happy you added that I will not be able to answer that question now. Like I said, the details of it will come. The plan we have, in fact, the roadmap we have, which I'd just like to share with you, is that we want the diseases to be decided first. Once they decide, they will say stroke is part, which I'm quite confident that stroke will be part. Then we bring in the experts who manage stroke. We bring in a number of them, 5, 6, 7. Then they go into a meeting where they map out what it means to care for someone with stroke, right from diagnosis to the chronic management. So how do you diagnose stroke? What are the acute interventions for stroke? How do you manage the risk factors or the causes, the hypertension and diabetes that come with it? How do you manage the complications that will come? How do you deal with rehabilitation? What will be their review regimen? What medications will they be on for life? So they will map out what it means to care for someone with stroke. Now, once that is done, we do the costing to each of these services. Then we can now agree on what the benefits package is. So if it is something, of course, you mentioned we shouldn't bite more than we can chew. So we look at all the from day one to the very end. The financials based on the numbers, the number of people who are getting stroke, the prevalence of stroke in the country, because we are not only picking new cases. like you mentioned, those who have had the condition for a number of years, should still be able to hop onto the system to receive care from where we take on from. So it's not just about the new cases, it's also about the cases currently in the system. So you look at all these numbers, look at the financial, and it's something we can do. We put it all, we bundle it all up into the benefits package. We assign the carriers, and we inform the necessary stakeholders and take it up. So for now, I cannot give you the details of what will actually go into the benefits package, but the specialists or the experts will give us everything, unless of course they leave out something, but I don't think they'll leave anything out because these are the experts who actually see the cases on a daily basis. So once they map it all out for us, we do the necessary action and we can decide what the benefits package should be. An issue of prevention was mentioned. Yes, so again, then MahamaCares cannot do it all. There are other agencies within the Ministry of Health. NHI is there. We have the Ghana Health Service, which has a number of offices and programs under it, and the free primary health care, and they have the mandate of prevention. So we don't want to overburden MahamaCares with prevention and treatment. MahamaCares will focus on the treatment. So where the primary health care has done this work in terms of prevention, in terms of screening and early detection, once they get it, NHI does it in providing care based on their tariffs, and then it escalates to a level, then MahamaCares come. So wanting us to do prevention, although it's a very good thing, I mean, health promotion and disease prevention is very key in our health sector, because once we do that very well, it actually reduces the burden of treatment from the MahamaCares. So it's in our interest that prevention and health promotion is done very well. But there is a separate agency for that, which will be run through the Ministry of Health. So we are hoping and we are very confident that we will do a very good job in the health promotion and health prevention. And that will ultimately reduce the numbers that we will have to deal with. But no matter how you do health prevention, health promotion, there are certain conditions we just can't prevent. They will still happen anyway. But that health promotion will teach them how to pick out the early signs. We'll teach them what they should do when they see it, so that we don't have cases coming in the very late stage. And that also compounds the cost of care. So this is the structure that we want to work with. So we will do more of treatment, but of course we are not going to dedicate prevention to the background. In our presentation, you will notice that we place emphasis on preventive work in cervical cancer, because it's one of the cancers that's of interest to the fund. And it's better that we prevent it than for them to come in very bad stage and that to increase the cost of care. So even some work is being done under prevention, but that's not our core mandate. That is why it doesn't feature under our pillars of our objectives. The primary health care will do that. Then there was the point about engaging FT. I think that is very welcome to something we take note of. We will reach out to the office and arrange some discussion as to how we can work together and collaborate to ensure that we do this right. Then there was a question about partnerships, as to how the civil societies can partner with the Ghana Medical Trust. I mean, civil societies, your scope of activities vary. So this will be specific with the civil societies. I mean, those that are into funding, health financing, I mean, we are happy to collaborate with you in terms of your technical support, your expertise as to how you can guide or support us in costing some of these services and putting the benefits package together. We appreciate that. Those that are in the business of raising funds to support patients, I mean, we'll be glad that you can help us also raise funds. That's great. But this cuts across all civil society advocacy. We want this message to get out there. We will do our best, but we are sure that we believe that we meet a lot of people. We engage with patients, we engage with local and international partners, we engage with average Ghanaians. We are hoping and we are trusting that you can partner with us by getting the message across. Every opportunity you get to talk to patients, let them know, I mean, that is fine. If we have to come in and it can be arranged, we can partner with some of these events where we get the message across. It's something that we can do. So these are some of the few models that we can partner with us. If you can link us up with international partners to support us with these equipment. We have some collaborations like that already, and we are open to all forms of collaboration as long as it aligns with our mandate and helps us achieve what we are here to do. Then there was a question about engagement of people who actually have the non-communicable diseases. Yes, this is very important. Like I said, it helps with the buy-in. So once you engage with as many stakeholders as possible, you just don't receive their ideas, but you receive their buy-in, and they believe that they own the policy, and they would work in making sure that that policy actually is successful. So we appreciate that comment. In as much as we engage with stakeholders, they are also one of the important stakeholders that we have to engage with. When it comes to the issue of non-communicable diseases, if we put all together, that's more than half of the country. So let's of course there are special groups. There are special groups, maybe there are special groups for sickle cell. And we are engaging such groups. Last week we were with the sickle cell group. So we met a group that has to do with sickle cell. So it was not just the caregivers, but also patients, their caregivers. I mean, not just the medical professionals, but patients, their parents, their caregivers, and relatives. We had a session with them and an engagement with them last week. So if there are certain groups that are available, we can have those engagements. But then, like I said, ultimately, we have to engage the entire nation because, I mean, health records are personal. But if we start here, a good number of us here are living with non-communicable diseases. Some will be diagnosing them for the first time because you may not even be aware because of how they happen. Because, like I said, he had it for about 9 years before it was even diagnosed. So it's possible that there are a number of us here who have the condition, we may not even be aware. So when it comes to the stakeholder engagement, we need to engage as many institutions as possible. Right now, our attention was even drawn to FDA. So it's not just those that directly are in the health space. We have to be engaged with finance, we have to engage with social welfare, we have to engage with organs. So we are open to such engagements. And once that organization is brought to our attention, I mean, we are ready to engage. Once we know of the existence of such an organization, we know that there's a group that has to do with, say, diabetes, there's a diabetes group, we are ready to have such engagements to get your opinions, because it's okay to talk to the doctors, it's okay to talk to the nurses, it's okay to talk to the industry players, but it's also very important to talk to those who actually have the condition, to also hear from their point of view what they expect from their caregivers and what they expect from us as industry players to be able to help them. So that's very much more.
Thank you very much. So we have 3 more add-ons, then we go for break.
Thank you. My name is Mara, Director of Operations from the National Health Insurance Authority. I've heard quite a number of mentions of the pre-primary health care. And I just want to put it in context what exactly we're doing with the pre-primary health care. So like you rightly said, the government has 2 flagship programs. Now the free primary health care and the paramedical trust fund. It doesn't mean that the NHIS as it exists is going to be defunct or to be cancelled. So visualize it as a sandwich. You have the bottom layer, which is the free primary health care. You have the NHIS, which is the filling in the middle. And you have the medical trust fund, which is the top cover. Now, NHIS has historically covered primary health care services. When you come and access care from the shift compound, health centers, maternity homes, all the way to the polyclinics, certain services at the polyclinics, and to the district hospital, those are all primary health care facilities. And we have done this over the past 20 odd years. What we are doing now is to reorient how we provide primary health care services, which means that going forward, most likely from the first quarter of next year, we'll be doing things a little bit differently. And the difference is this. Primary health care that we're providing at the moment is largely for curative services. NHIS did not pay for preventive and promotive services. And one of the reasons is that we were unable to quantify it, we were unable to track all these preventive and promotive services and create an appropriate tariff for it so we can reimburse our providers. What we are doing now with the free primary health care is 2 things. We are going to open the primary healthcare space to make it universally accessible to everyone. What this means is that you don't need an NHIS card to access service from the CHIPS compound all the way to the polyclinics. And I'll take that again. You wouldn't need an NHIS card to access primary healthcare services only from the CHIPS compound all the way to the polyclinics. We would have a defined basket of services, which includes medicines and curative services, and very heavy on preventive and promotive services. This prevention will include immunizations and screening services, and even disease surveillance at the community level. The second thing this policy will do, aside removing the barrier of having an NHIS card, is creating additional service delivery points. So it means beyond the CHIPS compound, we want to go further into the community. We are including community practice pharmacists in this policy. We've realized that a lot of people, that's their first point of call. We've all done it here, let's be honest. You go to the pharmacy with your diagnosis in hand, or you go there and ask for a diagnosis and then treatment all in one. They're a very key factor when it comes to prevention and promotive services. So we are including them in this policy. We piloted it last year through the National Telehealth platform, which we are currently running. And we created a tariff for community pharmacists to check your BP and to check your sugar. If it's within range, you're fine. Out of range, they have been trained to book a consultation for you with doctors in a particular network in the telehealth process. So we have done that. It works. So it's something we are including in the policy. The third thing about this policy is the fact that you would not need an NHIS card, but we would create a unique identifier for you, because at the end of the day, we should be able to identify who has gone to this particular service, so that when your claim comes, we are able to adjudicate the claim very well. It means that the NHIS, as it exists, we are taking out the services provided from CHIPS to polyclinics, but from the district hospital, the secondary and tertiary would still exist. The diabetes we cover, the hypertension services we cover, we will still cover it. It is not going anywhere. We are still covering it, which brings me to the point where how do we access Ghana Medical Trust Fund? You wouldn't just get up and go access services at the Ghana Medical Trust Fund. You would have to go through the chain of service provision. You enter through the free primary health care, you progress through the NHIS as it is, and then if the NHIS is unable to cater for you, develop complications, or there are services that are outside the scope of our benefit, that is when you graduate to the Ghana Medical Trust Fund. And as much as possible, we are going to ensure that it's a seamless process, right? It's a seamless process as you move through the continuum of care. We do not want to burden anybody. We do not want to put stumbling blocks in your way. You have to be able to go through the service provision seamlessly. And you would need to have an NHIS card once you're exiting that structure to the Ghana Medical Trust Fund. So my friend who said he has not had an NHIS card since 2012, you have to reconsider that decision, because you cannot access Ghana Medical Trust Fund benefits without having an NHIS card. The only service you'll be able to access without an NHIS card is the preventive promotive services and the curative services available at the primary health care space. The second thing I wanted to mention is that I had stroke care quite a number of times, acute stroke care. It's in our benefits fund in the NHIS. We need to be able to take care of you and convince the Ghana Medical Trust Fund that we are unable to cater for you within our scope of service before you can enjoy their benefits. So you would still need to pass through the NHIS. I get the impression that if we are doing away with the NHIS, we are not doing away with the NHIS. It will still be there. Diabetes and hypertension alone accounts for about 50% of our claims that we pay. We do a lot when it comes to diabetes and hypertension. And dialysis, it was introduced last year. It's part of the NHIS benefits package. At the moment, we're paying 8 sessions per month, that's twice a week. Some need more than twice a week. Then we can have a conversation with Ghana Medical Trust Fund. The people who are outside the scope of the 8 per month, these are some of the issues that the Ghana Medical Trust Fund can take up. We will have a sit-down. Conversations have been initiated with the Ghana Medical Trust Fund. I think we even have one later at the end of today. we will sit down, look at the benefits package, see where the clear lines have been drawn, where NHIS ends, where Ghana Medical Trust Fund begins, so that we are complementing each other rather than duplicating roles. We will make them very clear and we will communicate same to all our beneficiaries so that some of these confusions would not arise. I don't think if I've missed any other question on the entire
So yeah, the two then we are done.
I'm Alex Combat from the Ghana Revenue Authority. I'm extremely happy that the Medical Trust Fund Administrator is here. And I want to give just some comments. When you look at the presentation, there were some sources of funding for the fund. We talked about 3% NPL, parliamentary budget approvals, investment returns, grants, and then donations, voluntary contributions, and all that. So I was thinking these sources are not too reliable. And fortunately, I'm happy Madam is here. Fortunately, we have some low-hanging fruits. Why do I say this? So the government of Ghana has introduced taxes that we call the health taxes. And the health taxes are on products. Currently, we have about 8 categories of the products. And they are said to be main causes of the NCDs. And that is why government has decided to impose taxes on these products. They come under the Excise Amendment Act, that is 1108. Now, last year alone, we raked in 2.25 billion from these taxes. 2.25. I just went to our database and I pulled the revenue that we earned from the health taxes alone. So I wanted to make this appeal to you, Madam, that if it is possible that we can get part of these funds into the Medical Trust Fund, it will be very good. You see, when the taxes are collected, they go into the consolidated fund. And anytime funds go into the consolidated fund, I mean, they are used for anything at all, even doing interchanges. Meanwhile, the tax was imposed. We call it health tax. The tax was imposed on products that are causing the NCDs. That is the main objective of imposing the tax. So why should we rake in 2.25 billion, just 2024 alone, and this money is used for something else? So, Madam, this is low-hanging fruit for the Medical Trust Fund. If we can make a case out of this, that we are imposing health taxes, earning revenue, you can mention my name, earning revenue, and the funds are being used for something else. And if they can actually earmark, if not earmarking everything to the fund, but earmarking certain percentage to the fund, that would be very good. Because I see the 4 sources not to be too reliable. And when you look at the healthcare per person in Ghana, we are talking about $100. Healthcare is expensive. Unfortunately, we have money to take care of that. And the money is coming from imposition of taxes on these harmful products. So why should we allow the revenue earned from this imposition of taxes on these products to go into something else? We shouldn't allow that. So if we can take that up, we'll be very good.
Thank you. My name is Jeffrey Kautoka Sicilia, and I work with Revenue Organization Africa, so still coming from Revenue. And I happen to be a former friend of Madam Okobodia. We used to be friends. Yeah, that was on the lighter note. My senior, you mentioned something that I want us to consider, and that the state of health facilities, and he made a comment that break my mind about not blaming government. I'm sure you wanted to talk about not blaming an administration, because government is a continuum and government must be blamed when there's a problem. Like she rightly said, she visited the facilities and she was not happy at all. So again, once you are running your operations, the issue about corruption was raised. We need to fit it so well, because I was one, Dr. Combat knows myself and himself and some of our colleagues here were always talking about earmarking something to directly handle some of the cases of NCDs. So I feel more like it's a baby that I am part of the outdooring. So I beg you, we don't want to be that public account committee. And here's some of the things I'm hearing. So let's quickly, and then the wastage sometimes that comes with it. So corruption and wastage, let's keep our ears around it. Now let's come to innovative financing. I add to what my senior colleague just said about earmarking some of what, in fact, we call them the same taxes. These are the same four products that causes the NCDs that we are talking about. So he wanted to earmark some percentage, but I think we should take everything else and use it purposely for what it was meant for. And that is what we have to call. There's no two ways about it. It's the same product, the mess it causes. Let's use it to mop the mess that it causes. So I think I'll add my voice to even to a call where industry is still working. As we speak, industry is working for the removal of these taxes. So we will not join forces with you to call on government to maintain that pro-health taxes. The next one is also to look at the COVID levy. We have said this over and over for about 3 years. We've been campaigning for it to stay, and then maybe reword it and restructure it for the Fund-MahamaCares, as you see. My final one will look at the gold board, ensuring that a percentage of the gold, because of the mess that Galamsey is causing today, it is clear, I don't need to speak further, that our waters have been poisoned through the activities of Galamsey. And so a percentage of whatever they are getting from gold should be earmarked to come and mop the cases because of the cyanide and then the mercury they are putting in our waters. Even this one that we are confusedly calling pure water has deposits of metals in them. And so if we all agree that it's only proper that a percentage from whatever is gotten from the gold board fund should be earmarked for the treatment of these diseases. And I think it's important that we all make this a point that around this advocacy, maybe the collaboration between ourselves and your outfit will have to be the talk for one another. We are CSO, we are not higher than that. So when it gets to you, like your representative said, our institutions are in charge of that one. But we also allow it as time goes on. But these are the three main areas we should look for financing our healthcare, especially the Fund-MahamaCares projects.
So I just want to let us know we have had time. So we'll go just a 5-minute picture. It's not 15 minutes. Then we are back. And the other presenters, let's keep it straight to the point and keep the questions brief. So we'll leave here according to time. So let's keep it at the back.
So, pictures.
Our home control, road safety, policy advocate. He holds a higher professional diploma in marketing from Accra Technical University and a bachelor's degree in business administration. He also serves as executive director of Vision for Accelerated Sustainable Development, VAST Ghana. A CSO advancing health MBT through research and community outreach. Its efforts have influenced national NCD strategies, including integration into primary care and exercise reforms. Recognized by platforms like CAFA and Metaverse Africa, it champions multi-stakeholders accountability for sustainable health financing. He was recently awarded by the Virginia Forum for his outstanding contribution to tobacco control and age-related issues. Ladies and gentlemen, let's give it up for Brown Musa Kasawi. He's my boss, actually. Oh, we can do better. And 10 minutes, please.
Thank you very much. After when moderators stand before us, you wonder where they get those savings from. But that's fine. Thank you very much for taking me back to history. Yes, where I started from. And indeed, he was once a staff of Fund-MahamaCares and also the NCD Alliance. Yes, so thank you very much for those kind words. Right, so indeed, let me say that I'm also in my place to be. I'm finally doing all the things at the meeting, and a lot of issues have come out. And also grateful for the fact that the Ghana has gone and taken a lot of feedback that we all should have helps to advance public health, particularly communicable diseases. So I would go straight to my presentation. And let me say that indeed, a lot has been said already, and many of the things that are now my presentation also already said, so I'm not belabor the point. So I will go straight to the issue that we, as a citizen organization, led by Ghana Alliance, have put together so that we're able to advance this course. Right, so I'm looking at the series of effects or reflections with respect to the Ghana Trust Fund and how we can ensure that accountability is upheld throughout the process. Next slide. So I won't deliver the point on this, but the point that I want to talk about here is the fact that treatment costs also increase exponentially. We don't know diseases. That's why we in the past, I think today people say that it's the disease of the rich, right? And many people also mistakenly say that it's a lifestyle disease. We would normally say no, it's not a lifestyle disease. The moment you mention that fact, you take responsibility from the industry, from government, and you put it on the patient. So we want to run away from those, words. That okay, it's a lifestyle. You decide to go and get it, though it has we have moved from that conversation. Now, it is a disease that we must all, come together to ensure that we address, right? So next slide. So in terms of, again, the introduction, the fact that we are bearing the brunt of non-communicable diseases, especially low and middle income countries, and I've always said that I'm always amazed when you look at globally, when you look at the trend, 100% of disease burden, but surprisingly 80% or 70 to 80% is attributed to Africa, or the burden is more of Africans or low and middle income countries than the developing countries. So then I ask myself, when would that strategy change? So that we will now have 30% of this burden, and then the northern countries or northern upper country, western country will have the 70%. What would that happen? Because for many years we've been having 70, 30, 80, 20. But we need to work out so that we're able to change that permanently. And then also, this is due to exposure to non-communicable mental risk factors. And through our conversation, I don't think we've mentioned about mental health. I think it's important that we take that into consideration because these are also chronic and they can lead to a lot of conditions that we all regret. I remember last week when we had a meeting at Mesri looking at post declaration, national level mission declaration. One thing that came out has to do with mental health and the fact that many people are really struggling with mental health. And the moment somebody gets uncomfortable with disease, mental health set in
directly, automatically. You can't do, or let's say you can do about. So we need to emphasize that as well. And of course, we'll be happy to also hear from from the funds, could there be an opportunity for people with mental health condition to get access to that? But I'm happy what the National Insurance also mentioned. How the issue is going to be cascaded. So you move from one state to the other. So obviously, I know that there will be some mental health condition addressed, but we have to deliberate about it and ensure that at any point in time, mental health should always be something we'll be speaking about in our and then out-of-pocket spending for NCDs is expected to be as twice as high per visit to a health facility if we don't do much to curtail that, and that's something that we need to do. Next slide. According to the WHO, the world is off track, in achieving the SDGs. We all know that. So this is something that we must also take into consideration very well, and ensure that we are able to reduce the out-of-pocket payment that people living in SDGs face on daily basis. And then, yes, so I brought this slides. I'm sure the economic transport probably have seen this one, and obviously the national insurance, because this is from the health account, right? So if you look at the current health expenditure, if that's the blue line, that's the current expenditure for 2020. That's the blue line. But we look at for non-communicable diseases, it is very, very small, and it has been there trajectory, throughout the period. And there's a need for us to close the gap as much as we can. In fact, I made a presentation in Kenya, some few months back, together with the Ministry of Health, when we attended one event on NCDs. And I made a presentation, and I also made them understand that if the mama care is supported and it's mainstreamed, we would MahamaCares, it will reduce this identity. We will see that the burden of NCD will reduce, and also the investment or how much funds government dedicate to NCDs will rise, because currently the picture is not very good in terms of how much funds go to non-communicable diseases as compared to other disease conditions. Next slide. Right, so funding gap in mental health. So these are the funding gap. That's why I would thought that there's a need. So we have brought up just so the economic transfer will see the agency and the need to close that gap. What shocked me when we look at the statistics is the last end, which says that the funding gap is approximately about 98% point, almost about 100%, because little or nothing goes to support mental health conditions in the country, and we need to do much in terms of that. Next slide. Right, so what advocacy did you do? How did civil society contributed to the realization of the MahamaCare? In fact, let me say that we contributed immensely. Many people may not know, but the political actors, which actually backed the MahamaCares, we know that we played a central role. So there's an initiative that we have implemented that's called the NCD Manifesto. So every 4 years, we develop an NCD Manifesto where we catalog the concerns, the priorities, the issue that we think people in NCDs are facing the country, and then we make some key practical recommendations. So you consider the SLRs, Ghana, and partner civil society have consistently advocated for sustainable financing to finance our healthcare. And then the CSOs and people living with NCD, because we always work closely with them. Because we believe that you cannot build medicine for a sick person. You must necessarily bring them on board at the table when you are discussing development issues with respect to things that affect them. So we developed the manifesto on NCD for political parties ahead of the 2024 elections. And then within it, the manifesto urged political parties to prioritize NCD prevention, treatment, care, and support as part of the national development agenda, with a key recommendation to activate the NCD fund. Because, of course, I don't want to go into the nitty-gritty because I have explained the fact that we already have the NCD fund being mentioned in the NCD policy and strategy. Right? So, for us, when we heard about the MahamaCares or Ghana Medical Trust somewhere, why don't we activate some? But of course, this is for chronic non-communicable. So we will still be advocating for the fact that we need to activate, the NCD fund. So at least, or when eventually the government reduces because the policy expires in 2000 next year, and hopefully I know there will be some use, and then some recommendation will be given for a new one to develop. Hopefully we'll be able to integrate the government trust fund and also probably the NCD fund, which was mentioned in the strategy for the NCD policy. Next slide. Right, so with a major contribution to this effort was the communication. So with the communication, and I'm not sure if the among the research that the American Economic Fund did, they also took into consideration the financing burden of care of people living in cities in Ghana. The document that we developed that actually tried to project, the difficulties that people living in cities go through on daily basis, and then even the cost of treatment. So all were captured in this particular document, which was launched somewhere in 2022 or so. Right, so then we also embark on media advocacy, so I don't believe at the point of now. Civil society, particularly past Ghana, have also engaged in sustained stakeholder dialogue with the Ministry of Health, Ministry of Finance, Parliamentary Subcommittee for investing financing, because majority of our work has always been around innovative financing, domestic revenue mobilization to support our healthcare. In fact, we started this one long ago before the issue of donor funding started dropping. So we thought that the president controlled that advocacy and to ensure that at least some of the proposals that we have made over the years, government will listen to it and ensure that we are able to reduce the burden. Next slide. Now, so the fund represents an opportunity for us, that's what we think, an opportunity to close persistent health financing gaps that continue to limit access, which we have all heard today, and also the current funding source for Ghana Medical Trust Fund, including the 20% allocation to this one, gives us that we are very much supported, that we are very happy. But I also agree with the GRA that indeed that financing source is not, it's not very sustainable, and that we need a very long-term, sustainable, financing mechanism, so that after some years we don't have challenges with that with the Fund-MahamaCares, as we have seen with other interventions. Right, and also there is a need for dedicated domestic revenue stream to ensure predictable and sustainable health financing. This has also already been said by the GRA and then also Jeffrey. And it's important to link the Economic Trust Fund to a broader global health financing reforms. So currently there are reforms going on across the globe, and countries are earmarking, funds from health commodities to support their health. So we are looking at the map of alcohol, sugar sweetened beverages, as well as ultra processed foods. In fact, they are the major reason why, even I would say the major reason, one of the topmost reason why the Ghana Medical Trust Fund was formed. Because but for them, we wouldn't have had this problem and even created the medical trust. Then earmark the revenue from this, that's to serve as a sustainable source of funding, because no matter what you do, people will still smoke, people will still drink because of addictive nature, and the fact that there's no ban on these commodities. We can only put taxes on them. So why don't we levy or tax them? This has been going on for a long time. And I'm hoping that if the trust fund also in active voice, probably the government will listen and then earmark. The GRA, Ministry of Finance, the GRA have done their work. They have got tax. They know that if we earmark it well, it's like with the Ministry of Finance to do the needful by earmarking that. Then next slide. So moreover, the open-ended nature of the fund, I think this part is very, very important and crucial for us to society, and I hope that will be able to continue. Now, it says that the nature of the fund revenue sourcing, which allow contribution from corporate sector, risks creates a risk of undue influence from health harming industries. So the point is that you see the fund is too open. It's too open wide that anybody can contribute to it. But the question is, so when countries develop that document, they also come up with a code of conduct or a framework to guide, the operationalization of these funds, so that you don't have health harming commodity that impact on our health coming to contribute into these funds. Then it brings issues of conflicts of interest and also issues around, the fund the objective for which the fund is created will not be met. So we are very mindful of that. And for me, I mean, not only us, but even at the global level, everybody will try to ensure that, and try to ensure that we do not, how do you call it, take funds from a commodity that's already making profit for which you have created these funds, and yet taking money from them. So it creates that kind of conflict. So we need to be very mindful of that as well now. So this may undermine public health integrity and raise concern about conflict of interest in the funds operation. And this one has been already captured within the WHO framework, that we need to be very mindful of, engaging our family industry. That has created a problem that we are here to solve. Right? Then the governance and mechanisms should also allow for inclusion of people living with non-communicable disease and civil society organizations. So the point is that, throughout the consultation, we noticed that civil society, relevant private sector have all not been actively involved in terms of the structure. So the appeal is that if we are able to at least get, representative of the people who are civil society organization or people who are living the community to be part of the structure, it will help to ensure that we are, our voices are heard and are heard very much in the process. Next slide. So the fund design and implementation should also integrate the principles of the WHO framework for engagement of people living with non-communicable diseases. And this is very, very crucial because you have come up with a framework that we are building policies around NCDs, ensure that people who are affected most, people who you are designing this thing for, must be at the decision-making table. So that's the call that we are making, and reminding you of the fact that the WHO also make the call for governments all over the world to take into consideration. Next slide. Right, so I won't belabor the point on this. If we decide, we can share with you. We did some analysis, and we found that there's a need for the Ghana Medical Trust Fund to also take a look at it and see the cost-benefit analysis of action and inactions. Next slide. So in terms of strengthening accountability and transparency, so we would want to call for transparency and accountability, as that has mentioned already. And then the first credibility and sustainability depend on clear governance structure, open financial reporting, and inclusive oversight involving government, civil society. It shouldn't be only for, especially for accountability sake. When civil society should be involved. The private sector should be involved in terms of ensuring that the accountability is upheld. And then the first accountability begins with the establishment of a robust monitoring framework. I want to believe that definitely there was something like that, but we need to be very practical in that. And then when those are being developed, we shouldn't do it. Without people living with NCDs, without relevant private sector, without civil society organization. We must all be at table to ensure that this is, so at least we are able to have indicators that will measure, the successes and the challenges and the gaps, so that we are able to also provide proper recommendations for those. Next slide. So strengthening accountability also requires building, monitoring, and evaluation framework, which is similar to what I mentioned. The indicators should assess not only the funds that are spent, but also measurable health outcomes that are achieved. And that's the problem that we have with health promotion. And that's why we are able to invest in health promotion, even in the country, even at the global level. Donors are unwilling to support health promotion activities that are awareness raising because it's very difficult to measure. But as a country, if we invest into it, we are able to measure it after a long period. That's why we think that there's a need to have that kind of integration, so that we don't leave health promotion out of all of this. Now, the fund accountability also strengthened when guided by principle of equity, efficiency, and inclusivity. And these are terms that were not conjured by us, but are in very relevant documents, and it has worked in other countries, and they are benefiting from it. And then transparent governance and active stakeholder engagement will help ensure the Ghana Medical Trust Fund remains a sustainable instrument for improving health outcomes and advancing Ghana's progress towards universal health coverage and even beyond. Next slide. Right, so I will mention just about this one. I promote policy coherence by aligning the Ghana Medical Trust Fund with the universal health coverage roadmap. So that's very important. We need to draw the link, the roadmap, and then also the Ghana Medical Trust Fund, the national NCD policy, the Mental Health Act, to achieve an integrated and equitable sustainable financing stream for what we are currently discussing. Next slide. So in conclusion, before this one, in conclusion, Finally. Yeah, so in conclusion, these slides have always been one of my beautiful slides, especially after the Accra Summit, the African Health Sovereignty Health Summit, which was held in Accra. And this one actually cements or crystallizes, our core, our many years of core. The fact that to raise significant revenue for healthcare investment while reducing consumption of health farming products. Because, and that's the point that my brother tries to mention, the fact that if we don't put a lot of premium and emphasis on health promotion, the medical trust fund or national finance will eventually crash, because then many people are consuming on health commodity, they are getting all the complications, not much awareness creation is being done. So you get more people getting to the funds, and the funds are able to address the issue. So there's a need for that. So the WHO Director General, Tedros, his name, anyway. So he made a call at the 2025 Health Summit, indicating that hosted by the government of Ghana, to increase by 50% excise tax on natural commodities like tobacco, alcohol, sugary products, to boost health sector funding and save life amidst dwindling. In fact, so this was held just this year, and our president was there, the Minister of Finance was there, the Minister of Health was there when this town hall was made. So we are hoping, in fact, it's our hope that this budget that's been read, at least something of this nature will come up, where we will have at least some earmarking of these funds. Someone says we will take everything there, so at least we can have a sustainable, Ghana Medical Trust Fund. Now all of us will be proud of as Ghanaians. And I know that many countries, in fact, let me put this on record. Many countries are looking up to Ghana for this intervention. In fact, I mentioned the last time that we were speaking an ambassador for the Ghana Medical Trust Fund, because trust me, I have been a lot of statements across, the globe, anywhere for myself about this man, but I'm proud of it, and that's why I'm so passionate that we need to do all that we can to ensure that it succeeds. Because when it succeeds, all of us will be safe from the burden of non-communicable disease. Thank you very much.
Thank you so much, Laram. Oh, please, let's clap for him. Okay, we also take brief statements from our partners, but before we do that, let me acknowledge our sponsors and media partners. Ministry of Health, NCD Alliance in partnership with Leona M. and Harry B. Charitable Trust. Then to the media, we have Tobacco Media Group, GBC, GNA, then Business Finance Times. Welcome and thank you so much for being part of this program. So we start with Ghana Health Service, please, if they are here for your brief statement. Which slide? 5 minutes.
Thank you very much and good afternoon to you. I'm making this statement on behalf of the Director General of the Ghana Health Service, Dr. Samuel Akori-Yakaba. So I believe what I just to be there, but how to attend to other equally important engagements. Greetings to our directors and deputies from the various ministries, especially the Ministry of Health, other agencies, and the health partners, the leads and the representatives here, as well as to the various alliances. Ladies and gentlemen, I think this is the second opportunity I've had to listen to Fund-MahamaCares. I find myself in a position where I have to explain on some engagements, the difference between the free primary healthcare department and that team and the Fund-MahamaCares. And now I have a better understanding of what Fund-MahamaCares seeks to provide. The Ghana Health Service reaffirms its commitment to enhancing the health and well-being of Ghanaians, and through strategic partnerships and initiatives, as we see this afternoon, that's the Ghana Medical Trust Fund. And we are very much aware that this fund has been set up as an innovative response to the growing need for equitable access to healthcare. particularly for the NCDs and other conditions that require expensive treatments, which may not be covered by the National Nutritional Scheme. So this trust, or this fund, seeks to provide financial assistance for individuals who are facing catastrophic expenditures. And basically, these are health conditions that exceed their financial capabilities. And we are informed that the fund will direct resources towards the treatment of chronic conditions, especially the cancers, critical health issues, etc. And this aligns with our national health priorities of universal health coverage and sustainable health finance. And I'll use this opportunity to talk about some of your focus areas, being infrastructure development and capacity building. And as your assessment found, when it comes to infrastructure and equipment, we are not doing too well across the country. When you look at catastrophic expenditures, especially in healthcare, it's largely because patients are about to be referred for such services, diagnostics, and for some of the treatments, the providers are about to use their own equipment, allegedly brought in by themselves. So that increases the cost of care. So I think we're able to look at the area of logistics, equipment, etc. Diagnostics, that would be very beneficial. I've had the opportunity of being in China, South Korea, and a few other places, Egypt. And you visit their hospitals, they have a number of cubicles for ultrasounds, and they have a number of CT scan machines, a number of MRIs in the same facility. I don't think any facility in Ghana has more than one CT scan, one MRI, even BGMs. So when you go there, they have CT scans and MRIs that will during the day, and those that will during the night, and those are standby. Yeah, we have only one facility. So once it breaks, what happens? Patients have to move out, and that is additional cost to them. So let's look at these areas. Let's not just be happy with equipping them with 111, but let's also have partners. Then you have continuous provision of services, and that significantly will bring down the cost. We encourage collaboration among health partners, stakeholders, and the private sector to ensure that the Ghana Medical Trust Fund achieves its objectives. The Ghana Health Service believes that through collective efforts, we can bridge the existing healthcare gaps and ensure that every Ghanaian has access to the medical care they need. As we forge ahead, the Ghana Health Service stands ready to support the Ghana Medical Trust Fund and promote awareness about its activities. Together, we can build a healthier future for Ghana. Thank you very much.
So next we'll take from NHI. Please, if you are here. So since you need less than 5 minutes, I'll give you 3 minutes.
Thank you very much. I don't have a speech today, so I'm just going with us as we see. Thank you, everybody. Thank you for inviting us. As senior Minister of Health, as the Ghana Medical Trust Fund, joining the health sector, and everybody else, we're very glad to be here. My really greetings from the National Health Insurance Authority, as CEO Dr. Mwapo, who's asked me to be here today on behalf of the authority. The last presentation, Mr. Dragon, thank you very much for that presentation. I think it's not lost on us the importance of NCDs. Everybody in this room, at the very least, knows the benefit of this issue and appreciates all the difficulties that come with it. We, especially at the NHI, having been managing NCD for over 56% of the population over the last 20 years, feel it in our pockets, so to speak. If two conditions alone, diabetes and hypertension, account for 15% of the claims cost, then you know that is a very big issue for you to address. That is why the free primary healthcare, which I explained earlier, it's a that particular policy, which will be run by the National Health Insurance Scheme, will do two fundamental things. It will remove the barrier to access for primary health care, thereby universal access for primary health care services. And the second thing it's going to do is to include prevention and promotion activities into the NHIs, which hitherto was not a part of it. The second thing I'll say is that you mentioned mental health. NHI has not covered mental health in the past, but I'm happy to say that with our revised tariff taking effect from January next year, we have added 4 mental health conditions: schizophrenia, anxiety, bipolar disorder, and depression. Mental health management is very expensive, as we all know. NHI adds benefits incrementally. We start and ensure that we are able to cover it. Sustainability is at the core of what we do before we add additional benefits. So we're starting with 4. So bear with us as we see how that goes, and then we would add more as when the need arises. You mentioned also the out-of-pocket payments for NCDs. This is not lost on us at the NHI. We know very well that insured members still make out-of-pocket payments when they go to healthcare provider sites. We do not like it, you do not like it, but that's the biggest elephant in the room. We do have a problem, and the current management is committed to ending this particular issue. This has persisted over the years because of 2 reasons, according to our providers: delays in payments and low tariffs. Delays in payment is a thing of the past. If you follow the NHIs since January this year, payments are now done on a monthly basis. You can ask any healthcare provider. There is nothing like delayed payments among the NHI service providers anymore. And fundamentally, this is due to the uncapping of the NHI fund, which means that we don't have enough money from the Ministry of Finance as and when we have our claims and we are able to pay on time. The second thing is the low tariffs, which we do not have full control over. Whenever we revise the tariffs and agree on a cost for a particular disease, there are foreign fluctuations. The economy undertakes a very different turn, and then it affects the value of that tariff that we have costed at that time. And of course, healthcare providers are running a business. We all understand that. But you have to also understand that the NHI is operates within a very finite budget. We can only do so much revisions within a particular year. But again, the good news is that we have revised the tariffs. The tariff revision is complete. Again, we are looking at January for the full rollout of the new tariffs. And on record, all tariffs in the system that we have now, they have increased by an average of 100%. So the tariffs that are coming now are as realistic can be, which brings us to the point that when the tariffs go live, we do not expect any provider to take any money from anyone or turn anybody away from the access to healthcare because the tariffs are low. We have adjusted the tariffs and tariff revision. If you know anything about how NHI operates, we do not do tariff revision ourselves. We sit together with all the specialty consultants, what have you, policy makers, end users, and agree. When you go through the costing process, we all agree that this is the amount you pay for a particular service. So these 2 reforms, the uncapping leading to the constant or regular payment and the tariff review, we hope that the out-of-pocket payment that people suffering from NCDs have to endure will be a thing of the past. You also mentioned additional funding sources. I do hope that when you're considering additional funding sources for the Ghana Medical Trust Fund, you also consider the NHIs as well. Because when we start the free primary healthcare, we are opening the floodgates for everybody. We cover 56% of the population, which means when we start that policy, 100% anybody can join that pool and enjoy the services from CHIPS compound to polyclinics. So it's not just the Ghana Medical Trust Fund that needs additional sources. We also need funding to be able to add on the benefits as and when our disease burden calls for it. Again, the Accra Summit and the Accra research that was done during the United Nations General Assembly. What he didn't mention is that our CEO was also one of the facilitators. He's very much interested in sustainable financing, not just for the NHIS, but for the entire health sector. Since we're running these two flagship programs, and it's our main vehicle for achieving UHC by 2030. So we are looking at just not funding or sustainability, we're also looking at the governance architecture. How we even manage all these complementary services or policies to be able to ensure that we're doing it sustainably and we are able to use that as a tool for universal health coverage. Support for Ghana Medical Trust Fund. I think we are siblings. We are older siblings. We've been in the game for over 20 years. They are joining us now. The good thing is that we are running two complementary services. We are not in competition. We are doing two distinct things, but they are complement each other. So we will get to a time we will sit at the table. Conversations have been initiated. We need to be able to sit down, like I said, and structure the benefits such a way that we do not duplicate efforts and we are able to make use of the monies that have been allocated to us. So we are looking forward to more engagements with the Ghana Medical Trust Fund, and together we will, I mean, with everybody's commitment, we will make NCD management as seamless or as affordable as possible, from preventive through to curative, and if you have any complications, the Ghana Medical Trust Fund is there for you. Thank you for having us.
Thank you so much. And before GIZ gets on board, I would want to acknowledge the acting CEO of Mental Health. He just came in, Dr. Eugene Dodo. You're welcome. So please, GIZ. Sorry, mental health. What is yes. So I'm not supposed to be for that.
Right. Thank you very much for the opportunity to be a part of this important meeting. You know, when we were doing the introductions, they actually skipped those of us in the middle, and I was wondering what was going on if we could introduce ourselves. Okay, so I'll use this. Hi, my name is Juliet Ejia. I'm the project manager for the IR, Integrated Healthcare Initiative, and I'm a senior technical advisor at GIZ Ghana. All right, so maybe I go straight to it. We are asked to contribute remarks to how we are partnering with the Ghana Medical Trust Fund, or where the potential collaborations are. So first of all, I'll just give a brief about the project and how it feeds into the battery is running out. All right, so the IR Integrated Healthcare Initiative is a collaborative partnership between the Ministry of Health, the Ghana Health Service, and is implemented by GIZ on behalf of 3 pharmaceutical companies and 1 foundation. And we are focusing on strengthening the prevention, the management of non-communicable diseases, specifically cardiovascular diseases and diabetes type 2. So the IRON project is building on the achievements of the Ghana Heart Initiative, which focuses on the cardiovascular part only. And we have built a structure that has different models, so we can add more topics related to NCD, we can add more funding partners. It's a platform. Okay, so let me go into detail. Our first 3 models are looking at health system strengthening. So we are talking about providing support to enhance primary care. We are looking to improve screening and prevention of hypertension and type 2 diabetes in the communities, and to empower patients to take the active role in managing their health. Then we have our disease-specific models, which are focusing on cardiovascular diseases and diabetes type 2. Here we are building the capacity of health professionals specifically physician assistants, nurses, and medical for how they can improve in the work that they're doing for these patients. We are also providing support by way of equipment to the health facilities that are part of the project and all the tools that they require to improve the quality of their care. We have two more models, and these ones are looking at providing support to improve laboratory services related to NCD care. So we are currently running some needs assessment to look at where are the gaps when it comes to providing lab services for NCD care. We can look at the gaps and then intervene. And then we are providing support to the Ministry of Health for the National Research Conference, create a network and bring all key stakeholders around to share their work related to NCP research. Okay, so from the presentations that were given by the Medical Trust Fund, when we look at the core objectives that were mentioned, 4 of them that I took note of, you can see that the NIA project is already contributing to 3 of these. So when it comes to the capacity building, like I said, we already provided training for 6,000 health workers during the Ghana Heart Initiative, and for the NIA project, we'll be doing same for 2,500 health workers. So we're talking about trainings, building their capacity, the ACLS, BLS training, building up their capacity for improved care. Then when we look at screening, we were able to screen 10,000 people from the communities here in Accra, and in the NIA project, we are looking to screen 150,000 people. So we're talking about using a community health nurse to go into their homes, screen people, link them to care, and then provide them with support. When you look at the other core objective, the infrastructure, let me take it from the DHI all the way to the NIA project. During the DHI, we already provided equipment support to a team of 600,000 euros in Greater Accra and the other 10 regions, so a total of 11 regions. We provided equipment that were necessary for the management of okay, so we are talking about glucometers, we're talking about space, we're talking about the ECGs, defibrillators, and patient monitors. So when the administrator for the Ghana Medical Trust Fund was speaking very passionately, I was just nodding because it's the truth. In 10 regions, the support from Ghana Heart Initiative was what brought an ECG to health facilities like at the polyclinic, at the regional hospitals, and also things like defibrillators were not in these facilities. They did not have space, and glucometers, sometimes when we went to the chief's compound in the health center. So for one small project like us, we were able to contribute to that, enable these facilities to have the equipment that they required. We are also in the process of procuring some equipment now, the same kind of equipment for the iron project in all the regions and health facilities.
All right, thank you very much. So like I was saying, so the equipment is currently being procured as well for all the beneficiaries that will be under the IA. When it comes to your third core objective, which is talking about the medical research, next week, Tuesday, Wednesday, we are working closely with the Ministry of Health, and we are going to have the National Cancer Forum that gives the opportunity to lay the groundwork to build stronger interventions for the management of cancer.
And then the 20th, which is the Thursday, we are going to have the national conference for NCD research, where we are also going to use that opportunity to lay the groundwork for building NCD research. So from my point of view, all these interventions that the AYA project has feeds directly into the objectives of the Ghana Medical Trust Fund. Finally, we are also working with the national partners, Ministry of Health, the Ghana Health Service, working with all key stakeholders, including people living with the NCD, with the specialists. Thank you.
So to update some national documents that are required, for instance, we have a national guideline for the management of cardiovascular disease. That document has currently been revised and is waiting the signature of the health minister, and it will be used by all healthcare workers. We work with the national stakeholders to develop training manuals, which will then be used for the trainings. We are also working on standard operating procedures for therapeutic patient education, which the health workers will use, and also standard operating procedures for the patient support groups. So to end my presentation, what I would like to say is we need to find some kind of mechanism to be able to reach all the interventions that are currently happening in Ghana. There are some of the colleagues here who are also having similar projects, so that the nation will be able to map out and say, for this particular objective, when we add the output from the IR project, we have reached our objective. I believe that this will be really helpful to avoid duplication of efforts if we are all around the table. So it's really a pleasure to be invited, and some of this information may be missed if we are not around the table for the conversation. Thank you very much for the opportunity.
Thank you so much. We did more than 5 minutes, but that's fine. So next, we have the Clinton Health Access Initiative, the CHAI. Please, let's welcome. Since you're having a laptop, I'll give you 2 minutes. Yeah.
Good afternoon, everyone. I'll be very brief. My name is Clifford Kofi. I work as a senior analyst with the Clinton Health Access Initiative, CHAI, and that's how it's pronounced. Yeah. So on behalf of the Clinton Health Access Initiative, I'm honored to express our unwavering solidarity and deep commitment to the vision of the Ghana Medical Trust Fund. The establishment of this fund is so important, and you have no idea how many lives you are going to be saving just through what we are discussing here today. I have a background in clinical medicine, and one of the reasons I made the transition from medicine to public health was the sheer agony and mental torture that I had watching patients wither away from conditions that could be treated, but because they could not afford access to that treatment, or because we do not have the tools necessary to effect that treatment, they were dying. And at a point, it became too much to bear. So I decided to jump away from clinical health and move into public health to see what I could do to make these things much better in the system. So you have no idea how many lives are going to be saving through this Ghana Medical Trust Fund initiative. And CHAI is proud to stand with the Ministry of Health and the fund as a trusted technical partner. In Kenya and Tanzania, for example, we've been supporting the development of performance-based models for radiotherapy and other high-cost health technologies. We ensure equipment functionality, value for money procurement, and long-term service sustainability. So we look forward to adapting some of these lessons to Ghana's context and supporting the fund in designing efficient financing mechanisms, coordinated procurement systems, and price negotiations that can stretch resources further while expanding access to care. Together, we believe that we can build a system that not only delivers care for today's patients, but also protects the fund's long-term sustainability and ensures that no Ghanaian is denied treatment due to cost or availability. We are very proud to be part of this journey, and we reaffirm our unwavering support to the Ministry of Health, the Ghana Medical Trust Fund, and all partners working to make this vision a reality. Thank you very much.
Thank you very much, Mr. Chai. The word is Chai, right? Oh, okay. So we take another one from the Christian Health Association of Ghana. I think that one too is Chad, right? Okay, so I'll give you 1 minute since you are coming from the Christian background.
Thank you very much. I'll take 50 seconds. We didn't get the opportunity to introduce ourselves as well. So I'm representing my executive director, but my name is Alex Mensah, director at CHA. I've enjoyed the discussions, but I want to deviate a little bit from the norm. CHAG was instrumental in the formation of the National Health Insurance in Ghana. And personally, I was part of it at Nkoko before the law was passed. The same passion that we have to care for NCDs and people suffering, that is what brought about the idea for us to initiate schemes that later culminated with the National Health Insurance Scheme. I want to caution that as we try, discuss, and decide on what to do, let's not bite too much, as was already mentioned. I remember in 2000, a chief gave this same admonition. It is like those of us who have lived in the village, roasting a snail in the farm in firewood. If you don't allow the fire to be hot enough and you put the snail in it, the water from the snail will quench the fire. So you lose the fire and you lose the snail. So if we decide to do too much in haste and at the same time, we may end up killing the beautiful baby that we are birthing. So let's hasten slowly. And that is from CHAG, Christian Health Association of Ghana. Thank you very much.
Wow. Less than 50. You said you give me? All right, thank you so much. I think our welcome address is ready, so we'll take it again. Yes. So
Distinguished guests, esteemed colleagues, ladies and gentlemen, please forgive my inability to be with you in person this morning for this very important event. This is because of some unforeseen circumstances beyond my control. It's with great pleasure and a deep sense of purpose that I welcome you all to this strategic stakeholder engagement meeting on the implementation of the Ghana Medical Trust Fund, Mahama-Cares. Today we gather not just for another meeting, but to take a bold step toward something truly transformative, a future where every Ghanaian, no matter their background or income, can access the care they need without fear or hardship. For those of us in the NCD community, this conversation could not be more timely. Every day, people in our families, our communities, and our workplaces face the burden of non-communicable diseases, cancers, diabetes, hypertension, mental health challenges, chronic kidney failure, sickle cell disease, etc. And too often, they struggle in silence. The Mahama-Cares Fund represents hope. It represents a shift from promises to action, from rhetoric to real, sustainable investment in the health of our people. The Ghana NCD Alliance has long advocated for this, for equitable financing, access to essential medicines, and support systems that leave no one behind. And so we are deeply encouraged to see this initiative taking shape. But friends, our work does not end here. The success of this fund will depend on how we, as stakeholders, come together. Government, civil society, the private sector, and our developmental partners to make it transparent, accountable, and truly responsive to the needs of our patients. Let us approach today's discussion with open minds and a shared vision. Let's remain guided by three key priorities: equity, ensuring that no Ghanaian is left behind, regardless of geography or income. Number two, accountability, building a fund that earns and maintains public trust. And three, impact, translating policies into tangible improvements in the lives of patients and families. Together, we have an opportunity to chart a new path for health financing in Ghana, one that secures hope, dignity, and better health outcomes for generations to come. If we can achieve that, then MahamaCares will not just be a fund, it will be a legacy, a legacy of compassion, fairness, and dignity in healthcare for every Ghanaian. On behalf of the Ghana
Okay, thank you so much. We take the last one from the persons leading with NCDs. And Chris will do that for us.
Forgive my height. So I'm not in the middle. Thank you. Good afternoon again. Yes, thank you. I don't take opportunities to speak on behalf of my community lightly, and so though it's too late, I still accept it. I want to say that once again, when it comes to health and interventions, we take it wholeheartedly because we are the only ones who know what we go through every day. We know the expenses, we know the out-of-pocket expenses, even for caregivers. We know what it means. I have seen my mom go through shades of, depression, and she's happy now because though we live apart now, I'm still, active, and she's just hearing good news. So when I'm going to my communications, I look at every day good news, and she's happy. This February, we had the opportunity to be in Rwanda to speak at the NCD forum, and one of the things I said, which I'm still echoing and I will continue to echo, is persons living with NCDs are experts. The lived experience is an expertise on its own. When you go through school, you become, you go through degree, your master's degree, your doctorate, and all of that. Because you've gone through that system, you are known as an expert. You are certified. So then you are called a doctor, you go to work, come back, you are recognized. What happens is that when you go home, you have the luxury of putting the title aside and then being the family person that you are to your brother, your sister, or your wife, husband, your kids. For persons living on NCDs, when we go through the day as experts in the room, we don't have the luxury of telling the diabetes that, okay, now that I'm home, sit somewhere and let me also be who I want to be to my family. I don't get home and say, now that I'm out of my wheelchair and I can move around my house by putting my lived experience aside and being who I want to be at home. So you can imagine our level of expertise. It goes beyond what you can imagine. The complications we deal with, sometimes we even deal with it when we are sleeping. So it's not as though ours comes when our minds are on it. Different shades. So when I say we are experts, because when we call for meaningful involvement, the question that we keep getting is, why should you be involved when they are experts? That's why when you spoke, I said, I see a lot of leaning towards specialists. We are specialists. Me, based off of my experience, I have helped a lot of other people deal with their conditions. There's a friend whose mom was taking medications and it was affecting her mentally. It was affecting. I told her, listen, you have to get to a point where you begin to listen to your body. When the medications are too much, you have to find a way, seek expert advice, and cut it down. She wasn't listening. So she went to the doctor and the doctor told her the same thing. I said, listen. And now her mom is fine. So as we move along, as we have this conversation, as we seek healthcare for persons living with NCDs, never take that mother who comes to the health facility for granted. She said she may be a caregiver, but you have no idea the experience she has. When that adult wakes up at night because of anxiety or depression, because of a seizure, and she has to watch the child go through what he or she is going through. She knows that expertise. So when she's advising, she may not advise based off of medical lines, terminologies. She may not give you what you learn in school, but she will give you what she learns in darkness, what you don't see under a microscope, what you will not diagnose because of radiology or an MRI scan, but what you gain based off of experience. And that, trust me, goes a long way into merging what you learn in school and what you learn through experience to giving us the medical care that we seek. We don't want cats. We don't want that. We don't want to come here 4 years later and say that indeed there was a Mahama Care, there was a Ghana Medical Trust Fund, but it didn't have the impact that we hope it would have. We want to come back here 4 years from now, 8 years, 12 years, 20 years, and say that, look, if it had not been for that trust fund, I may not be alive today. So persons living with NCDs, I expect the letters begin to recognize them as such. Thank you.
You did 4 minutes.
Okay.
Okay, so since we are talking about health, I think on our list of items we have walking the talk, and I'll invite for you to come and help us with that. Walking the talk. So walk the talk. Walk the talk.
All right, thank you very much, Jesse. Adovia. Anyway, so basically, I have always led this session because it falls within my domain in the office as a program manager for the Ghana NC Alliance and Fund on the issue of physical activity. Yeah, it has been a top priority. We don't joke with it. And we want to find a way to ensure that every organization, private government, at least once in a week are able to dedicate 2 or at least 1 hour for a physical activity session. Yeah. My boss, I don't know, those of you who are on platform with Zima Brown, we do it in the office on Thursday, then he goes with the family on Saturdays at Aibinsa to Pediasi Lodge. He climbed the mountain, very important. And we are planning something in that direction with the MOH as well on the 12th of December, the UNC Day. And then the following day, we shall be going for the Great Walk I mentioned to April. Yeah, those of you who have the capacity, you can join us. So basically, we want to share a bit of that in the office, working the talk. I don't know if you have any of our videos, but if not, wherever you are, please kindly be outstanding. Yeah, let me invite my senior instructor to join me, Ampoma. Yeah, yeah, my senior instructor from Ukraine. He was in the army. Yeah, sit up. All right, so we want to just, we've been sitting now for quite some time, and we want to at least shake our body. All right, so let's have a bit of a stretch up. Very important. If I want to lead, I'm sure most of you will be able to work after this session. That's why I have to invite the man who addressed diplomatically to lead us. And by that, we are not going to stress so much. All right, so wherever you are, kindly stretch.
Pull it up. Now try and have something that you are try and on your toes.
On your toes.
Yes. Want to keep those who are straight. They are pushing the walls down. Alright, now bring it down so you bring your hands down. Okay, now we are going down. The same hands stretched.
Okay, stretch.
Bring it up as I do. Bring it down. Okay. Then two. Try to cut something down. Feel it.
Yeah, you can feel it in your waist. Yes, at your own pace.
Bring it up again. And bring it up yourself. Alright. Now try and do as I do.
Okay. Right and left.
Right. So now we are going to
slow but sure.
So let's go. Left, right, left, right, left. Then you hold for your right. All right. Now you hold your waist. Try and look through like that. As I'm doing.
To the right.
Stretch. Try and look at your back. And then the doctor tells you to stop. Now let's bring it back to the other side.
To the left.
Now bring it forward again.
Just do the right thing.
Try and raise it back.
Okay.
And bring it down and remain steady. Now, with your right hand up, let's see if we can do some clapping. See how clear it is. Now, with your left hand up, see how difficult it is. Let's go. I hope it's difficult.
Yeah, very difficult.
So what this means is that when you keep trying it, it will also be better. And so there is no disability anywhere. It's just because you don't use the other side.
Very important.
Thank you so much.
Thank you very much. Can you take your seat? Yeah, so as you can see, this is what we do in the office. This was part of what you observe breast cancer awareness session, very important in the office. Yeah, so we encourage at least every institution to get something of that sort and be doing. Yeah, the WHO has a very nice MOH. They have a very nice facility. You know, you can write to them for partnership or just to use the place. A very nice facility. And we shall be accessing it on the 12th of December, hopefully. You can join us and then on the Great Walk, 30th to the 30th December, the Great Walk from Ayito to the Free Gardens. Yeah, it's a full day event. Just come as you are. For refreshment, you don't have any problem. You just come. You eat and drink. Thank you.
Thank you so much, Solo. I saw Dr. Ignatius do it very well. Doctor, what's the secret? You were so relaxed. Yes. Or later, you've been doing it. Oh, okay. So if Doc is doing it, I think we should all do it. All right. Okay. So I think we are here basically for Fund-MahamaCares. So we are coming to look at this is an open forum. We are coming to bring out our input. What are some of the practical things we can bring out to help with this initiative? Okay. So that one, brief. 30 seconds, 30 seconds, everybody. Not 30 seconds. You want?
Thank you very much. My name is Christian Zapa. I work with PAP. Number one, we're going to need some very clear guidelines to make this work. And I'm very happy that NHI is here. Guidelines to show where does NHIS end, where does the medical trust fund take over. So guidelines very important. Two, which conditions are we going to focus on? I'm very happy that the boss of the Mental Health Authority is here. But you know, last week we had a meeting and I advocated and I'll continue to advocate that we're going to need mental health to stand on its own because the budget is too small and the issues are many and varied. So I think that maybe before we leave this place, Doc will have a discussion with the Medical Trust Fund team so that we know where we can merge the two or where we can divorce the two. So we need guidelines and we need protocols. I have heard us talk about the fact that a clinician will have to make a recommendation. I think that might be better than asking the patients to send the recommendation themselves. You create a website and you say if you need help, put it there. Everybody, including me, will put it there because I also have a case. I have hypotension. It's somehow it's not nobody ever talks about it. But people can easily die out of low blood pressure and you won't even know. So the last point I will make is let's be careful how we involve the private sector. Private hospitals and private diagnostic centers, because we're talking about primary level, secondary level, tertiary level. And with the private hospitals, it's not so clear cut as to whether this is a primary hospital, this is a secondary, so let's know. And also, I hate to say this, but I will mention it. A lot of people with NCDs are going to alternative healthcare providers. Epididro, puncture, and all those things. I don't know how we're going to involve them, but the guidelines should be clear, or the protocols must be clear that what kind of service you're going to support. I will leave it here. Oh, with PATH, one of the things we're looking at currently is we have developed what we call the NCD Navigator. That helps us to know who's intervening in what area and where, in which part of the country. This might help us to know where equipment is needed, what kind of equipment is needed, so that we make sure that equipment, diagnostic equipment, are equitably distributed all over the country. I have worked in every region in this country, and I can attest to the fact that the needs are major and we need to approach them one by one by one. Thank you.
Okay, we are still taking inputs. Practical ones. Yes. Inputs. Not questions. So, Dr. Eugene, right?
I mean, so far I don't know whether MahamaCares has actually added mental health, but it's the cry we've always had that we talk about NCDs and we kind of leave out mental health. It's great. Health insurance is talking about the 4 conditions they will start to reimburse us from next year. But definitely people with these conditions also get complications, just as those with NCDs get complications. Mental illness is a disease of young people. We get young people who, cut short their studies, their training because of a mental disorder. And these people might not be able to reach their fullest potential just because of having a mental disorder. And it's very important that we don't just look at treating them with the medication, but helping them to find an alternate, something they can do to also be functional in society. So I'll be very grateful to have the Fund-MahamaCare actually add complications of mental health to what they have, and then see how best. Currently mental health is severely underfunded, even though it's been shown to cause a lot of loss in GDP, up to about 70% of GDP, but we still don't invest enough in mental health. So it would be great if we could do this little investment in mental health, especially for the young people who need something to help them and not just the medication. Thank you.
Thank you very much. Thank you all for being part of this timely and important forum. My name is Kitty and I work with Fund-MahamaCares. And I'll say that I like how the Dr. Marion from HIA put this as a sandwich. Tackling all areas for those in the community, free primary health care, while keeping the NHIA performing its functions. And then making sure that those that fall outside the NHIA also receive the care they need. And in doing this, it's important that we look at what other stakeholders are doing. I'm glad Pat mentioned the NCB, is a collaborator or navigator. Because when Juliet was speaking, I could see a lot of the things that we do in Fund-MahamaCares being reflected. We work on a more value-based care approach. And we have a 3-tiered level where we are, first of all, building clinician and health worker capacity to give patients a better experience of care with a focus on improved clinical outcomes. And then secondly, we also work on digital care because we generated evidence that when you include digital care in the patient care journey, it generates better outcomes. The literature is out there. And also at the community level, we work with patient groups. So we are engaging patients who will be beneficiaries of this free primary health care. We're empowering them. In one of our recent engagements, for instance, at the patient group level, a fetish priest just walks in curious. What is happening here? In the course of the engagement, they take her blood pressure. It was astronomically high. And she got converted to the hospital immediately. So all I'm saying is that we really need to look at what colleagues, NGOs, DPs are doing on the ground and kind of find a way of synchronizing our efforts, because every effort feeds in. And to make this work and to make this cost efficient, we have to look at the entire continuum of the patient journey, from the one that's in the community, the one who would rather go to the pharmacy for their care, and the one who actually goes to the hospital, and the one whose care will not be covered by NHIA, and how they can tap into the Fund-MahamaCares. And in doing so, how we can ensure that we do that in a cost-efficient manner. Because if we are efficient in the community, if we engage patients, if we look at having remote means of getting patients to monitor their outcomes, blood pressure, blood sugar, etc., we can even prevent many of the complications before they get to the point where the NHI can no longer take care of them and they have to be escalated to Mahama Fund. So in summary, I'm saying that we should work together. DPs, the NHIS, Fund-MahamaCares, all of us need to work together and also make sure that the patient's voice is heard and is an important part of the conversation. Thank you.
Thank you so much. Okay.
Thank you very much. Dr. Benson, Institutional Care Division, Ghana Health Service. I would just want to say that the team should think big, but let's cast small. Let's think big in terms of comprehensiveness of care being provided. So let's ensure that the facilities we are working with can provide comprehensive care. All the logistics needed, the personnel needed are available. That significantly reduces the cost of care. Then we can get a one-stop shop with everything in this house. But let's start small in terms of the number of facilities we start with. That will allow increase or bring on board additional facilities. And of course, again, the number of conditions we are looking at, which will bring into the package. Let's start with the minimum number of conditions and add on by time. So we can learn lessons, and then learn lessons from the challenge we face before I will bring on board some more. So that's what I'll do to take.
All right, so money is basically one the fund targets almost every Ghanaian. Is there a cut-off point? Like you accept 50%, 10%, probably people create, I don't know whether it's Momo or a separate thing or that anybody at all, just like the way we do in our church. Before you enter the church, there's a box like touching life ministry. Whatever you have, probably you know, share. Yeah, basically, so that you can get some more support from everybody. It shouldn't just be limited to people who have a card, like the GoGo. What GoGo can give, I cannot give. But probably also have something to share. My 10 CD, 20 CD, or whatever can also be probably people consider that going forward. Thank you.
Okay.
Yes. Talk from eventual non-violent now. We will consider having a full Fund-MahamaCares as part of the health. And how do we represent that? If you understand this,
more inputs. How are we going to sustain the I'm thinking the one business have been referred to Fund-MahamaCares and their physical or digital issues resolved. Are we going to think of describing them because beyond that physical maybe this 25 does not count. They might have their procedure or whatever done and establish a point where they could go back to the 25 because this is the wrong thing. So are we also collecting figuring out that protocol or that pathway to identify at which point a patient can successfully exit Fund-MahamaCares and be back in the mainstream? Any more? Okay, so
Thank you very much. I know this is time for input, but I just want to also share my input in the way of addressing some of the concerns raised. So also the issue of exploring other streams by which individuals can donate even they are very little. So this is on the table. We have considered some ways of raising funds. One example is the round it up policy. So for example, you go into a shop like Malcolm, you buy something, after your shopping, you spend 250 CDs, 49 pesos. Most of the time, they round it up to a round figure and leave that 51 pesos with them. So we want to engage some of these big retail companies where we can round up that amount. That amount would now not be given to them. So instead of taking your 51 pesos or leaving it with Malcolm, now you leave that 51 pesos with us. We are also talking to how do we receive that amount? Also, once they do once it's entered into the system, the exact amount is entered in the system. So we can reconcile those figures with what's on the system with that. And this is an arrangement we are going to have with them. So it's not as if it's a law that they are trying to beat the system. This is also their contribution to the fund. Because most of the time what happens is that those monies do not actually, it might not even end up with Malcolm itself. It might end up with some cashiers somewhere. So we'll put the systems in place to ensure that those monies that are rounded up can come. So that's one aspect of it. We also want to bring about short codes by which people can donate through Momo. And also, there was a time we are copying from what the UAE is doing. They have something similar like that. So they also have these boxes at the airports and other places where they raise funds also for health. So once you have such boxes at such vantage places, restaurants, the airports, places that there's a lot of money that is expended, we are hoping that we would raise some little from those places. And I'm sure once you raise a little from so many places, it becomes a lot. On the issue of getting people off the MahamaCares. So what MahamaCares does is that we are looking at chronic non-communicable diseases. So most of the diseases, by virtue of the definition, will be managed long-term. Most of them for life. For example, majority of people have hypertension, diabetes, take their medications for life. If you're on stroke, if you have a stroke, you can be out of the acute phase, you can regain function, but you will still be on medications, you'll be on periodic reviews to prevent another stroke. So you are still on the system. An individual has a cancer, but they are periodic checks. So it's a long-term management. I appreciate the fact that there are people who may not need expensive procedures. They may not need that high-level specialized care anymore, and they can be sort of downgraded to the lower levels of care. In that case, they will automatically fall within we mustn't have a system or a point where we say, okay, you are now off the MahamaCares. So let me give you an example. So when it comes to, say, kidney disease and hypertension, most of the kidney diseases are complications from uncontrolled hypertension and diabetes. Now, hypertension and diabetes are being managed under the National Health Insurance. Let's assume management of kidney disease, which is a complication of hypertension and diabetes, is under MahamaCares. So the person is being managed for his hypertension for say 10 years, 15 years. Then it gets to the point that the kidneys fail and he goes on MahamaCares. Typically, once you have a kidney disease, it's for life, but of course there are medical miracles. There are very few instances that you have patients on dialysis, and after a few sessions, you repeat their function, and everything is restored. Once that is restored, you are not doing dialysis again. So MahamaCares is not paying for anything. Now, what is left is the management of your hypertension, which health insurance is taking care of you. So automatically you revert to the previous level. So there's, we can consider having a system, but we started in such a way that based on the service that you will find, we actually put you either the National Health Insurance or the MahamaCares. And practically, you have patients who will be benefiting even from all three, in that the patient lives in a rural community where primary health care is from, say, a district hospital or a TIPS compound. But this person has some hypertension, which will be covered for by health insurance. The person with hypertension can also have a cancer that will also be managed by MahamaCares. So the fact that you are on MahamaCares does not exclude you from benefiting from national health insurance based on the condition you have and based on the agency that will handle it. So we are expecting to have a meeting with National Health Insurance tomorrow, where we can discuss some of these things. The honest truth is that National Health Insurance virtually touches almost every condition, but the extent or the degree to the coverage, the degree of coverage is what the issue would be. So our discussions would center on two options. For example, when we talk about hypertension, they may not cover certain complications like hypertensive heart disease and the rest. We allow them cover hypertension, we come and cover the complications they don't cover, or we will take hypertension totally from them. So those are the two discussions we have. Taking completely from them automatically will put a strain on our financial. So we are also of the opinion that how about we take conditions that you don't touch at all, like prostate cancer? There's no package. As far as I'm aware, there's no package for prostate cancer. So can we take prostate cancer fully from its diagnosis to after surgery care or chemo or radiation, whatever? So they do what they are doing. They will take up one full condition and there isn't any overlap. But this is up to discussion. When we have that engagement, we can find some of these things and bring clarity, like was requested, so that we know where NHIS is and where the MahamaCares starts.
Okay, so Labramo,
when we were actually looking about setting out maybe some boxes around airports and some public places to raise funds. And also, I want us to maybe consider how, of course, when you go to Rwanda, they have car-free days, where, of course, that is dedicated to prevent NCUs. So usually they don't use cars on particular days just for walking. And to make sense of what we mean about MahamaCares, would it be possible maybe to set up a day, for instance, a special day dedicated that, of course, we want to raise funds, whereby the secretariat will liaise with other telcos, like the telecom, like MTN, Vodafone. So, of course, messages will be sent, circulated across for people to donate a little penny into that particular account. And I believe that, of course, if we exhaust all these, like through physical donation, through SMS donation and the like, I think we will be able to achieve, and I think that's the way to support, because sustainability is key. I was also saying, for instance, the issue of stroke care, as I said earlier, much of the burden is centered around post-discharge. When one is being discharged from the hospital, the person comes home, the person may need assistive technology, like walking aid, throwing chairs. I can't remember they said one of the things here, Chris, there was a time he was looking for wheelchairs and stuff like that. The stress that he went through, in fact, it's something that we also have to consider. That's why initially I made a comment that, of course, we should consider how, I know you cannot tackle everything on board, but there are some times, like things like post-discharge support, that need, of course, useful support to support person living stroke. No, we deal with person living stroke in our community, and we know how much they are going through. Maybe they can't afford simple wheelchairs and stuff like that. So if there is an initiative to support that, I know it's not a huge burden. If we have that decentralized process whereby government can even solicit for maybe purchase wheelchairs for certain people who need them urgently, and then we go a long way to support those in as well.
Okay, so
and lastly, I think I need some clarification from Dr. Agnew. In your remarks, you mentioned that one needs to register for the market. Is there a registration process attached to it?
So the registration process is under the National Health Insurance Scheme. And this is, the whole idea is not that we want you to register because of the premium you pay, not necessarily because of that, but because we want to be sure that you have gone through the process of the various tiers in the health sector. Like I said, MahamaCares will do with specialized care. And before you get to specialized care, you should have gone through, it is taken off from where the NHIS ended. Now you are not even on the NHIS in the first place. Why are you moving on to want to access care for a condition that we have made provision to be taken care of under the NHIS? I don't know if you are getting it. And it also helps us with our database to reconcile the information. I mean, if you are treating people and there is no base, there's no registration in some sense, then it becomes a problem. And we don't want to create a system where you have to have a totally different registration process. So once you register under the National Health Insurance, it qualifies you to benefit from NHIS, and also qualifies you to benefit from MahamaCares, so that you have that record.
So it's actually linked to the National Insurance.
Now, National Health is even linked to Ghana Card. So essentially, we are getting.
Okay, hello.
What I want to tell people is that, of course, it shouldn't be like a new registration process for someone to benefit from what is there.
That's not the plan. That's not the plan. We don't want to give any new registration system. So we are taking advantage of the existing systems in the healthcare process. Let's use like you are paying for one to get into. You are getting another one. You are registering for NHI and getting MahamaCares as well. That's the plan.
Right. So thank you very much for the bilateral discussion. Yes, I'm sure the conversation will start. We have so many questions. I don't think that probably this platform will be able to answer all of them. I know even as we move to our various destinations, questions will come up, and our platforms are ready to accept them. And then probably when we are able to get opportunity to meet with the the Ghana Medical Trust Fund Secretariat, we would be able to share with them some of the concerns that have come up. So, in terms of way forward, I mean, from us as the NCLS Ghana, what we, and let me say, first of all, we are happy to collaborate with the Ministry of Health. And in fact, our collaboration is very, very strong, and we hope that it will continue unabated even into the future. And hopefully, the doors open for us at the Ghana Medical Trust Fund to also collaborate more closely to ensure that the civil society activism in terms of how we roll out our programs to cover nationwide, so people begin to understand and then where to actually assess, the care and how the modality for all of this. Now, having said this, we still have some programs that we have outlined, which resonate with all of us. Just for you to know that we are planning a conference, just as GIS is also planning. Hopefully, we'll collaborate with them to make sure that it is done very well. That is a conference or a stakeholder engagement, but this time around for non-health sector, because I think that we've been having conversation with the health sector for far too long, and there's a need to broaden the scope, the stakeholdership, and bring in the non-health sector in talking about the institutions that work that are not primarily working with the health sector. How do we bring them on board? Share with them some of these things. How can they also contribute immensely to achieving? Because if they don't understand these things, how can they be willing to also contribute? So we are planning a conference like that, hopefully next year, to get that done. Now, 2025 mark is the day that we have set aside by the WHO for UAC Day, and we are also hoping to have a collaboration with the Ministry of Health to hold a UAC Day, where, of course, everything that has been discussed here is a huge concern, and we need to continue to see how do we reflect on the Ghana's roadmap, UAC roadmap. What have we achieved so far? Where are gaps? And how can all of us together, give recommendation how to improve or strengthen the implementation of the Ghana's UAC roadmap. And of course, our focus will always be, on non-communicable diseases, because we feel that at any point in time, NCD has always been relegated, the background. And thankfully, we are seeing that kind of elevation even in Ghana. Now, so having said that, we are ready to support, the Mechanical Trust Fund, the planning. In fact, I know the design and everything has been done, but going forward, we would definitely would request for a start table, at the decision-making table, so we can discuss thoroughly, the issues that we think are affecting people living, because we work with them closely, so we understand their situation, their condition. So having a platform with you will be very appreciated. And also that will help us also support the implementation of professionalization of the Ghana Medical Trust Fund, especially the fact that it has not yet, fully taken effect. But of course, as you said, some work has already been done. So we are ready to support with awareness creation. Of course, on the Ghana Medical Trust Fund, especially on the NCD risk factors, which we are already doing. So we are hoping that the government could also, at least give us some funds to support their this intervention. I'm not seeing the NHI here, but once the free primary healthcare intervention is rolled out, we are hoping that at least there's some funds dedicated also to support civil society work in terms of awareness creation, because we are also able to reach the masses. And trust me, it is not only government sector that the people listen to. They also listen to civil society a lot. And we have people in NCDs who speak, and when they speak, it resonates with the people, because they feel that these are people who are living with a condition, so they are able to open up and then let them understand from the issue they are having, and then ready to hold, the secretariat also into account. Transparency, accountability is one of our hallmark, and we will ensure that at least on regular basis we would, call for, some accountability mechanism. And we've already mentioned that there's a need for a framework. That would help to, and then when that framework is done with indicators and is published, we all have it, and we are able to, to check the box to ensure that at least we are able to address the issues that are pertinent. And then Also provide our technical support to the fund, because we have expertise from people in NCDs, from our global partners, and I think we also have private sector here who are also ready to support, the fund, because we can't let it fail. And then finally, we are ready to meet with the authorities, as I mentioned earlier, and then hope that the platform will continue. We hope that this platform, a platform like this, it can be beyond this one. We'll continue where we'll have, regular discussions. Because if we say we'll wait, obviously things will not go well. So if we're able to have these regular discussions, so that's why I would call on, the private sector present here who have made intervention. How can we come together and then support in such platforms? We meet, discuss, national insurance share with us, economic platform share with us what they have done, where are the gaps, how can we fill in the gaps? Then gradually we are all making inroads. We are ready to also share recommendation to support the fund. So basically, I think that is what, and I'm happy for the fund, at least when we call on you within the short time, you're able to come and then give us this presentation. So on that note, I will say thank you very much. Before the thank you is properly given. So I will take my seat. Thank you very much for your attention.
Thank you very much. We'll take our last words, and that will be our closing remarks as well from Dr. Eugene Udui. Please, let's welcome him.
Very brief. Thank you very much. And on behalf of the Mental Health Authority, we want to express our sincere appreciation to everybody, especially to my colleague who is championing mental health. And we are happy for this fund, for the Fund-MahamaCares Fund. But more importantly, we want to say that this initiative is a significant step toward a coordinated national response to the growing burden of NCD and mental health. It reminds us that effective health systems are built not only on infrastructure and policy, but also on empathy, foresight, and partnership. And I like the part where everybody's given the opportunity to make a contribution. So mental health still remains an integral component of this vision. The authority is committed to working collaboratively with all stakeholders to ensure that prevention, early detection, treatment, and rehabilitation are all embedded within the broader NCD framework. Together, we can build a health system that truly leaves no one behind. When the drum of duty sounds, every hand must find its task. We are happy to be here today. Let's unite our resources, our expertise, more importantly, the compassion we all have for the collective well-being of our people, and to note that there's no health without mental health. Thank you very much.
There's no health without mental health. Okay, thank you so much. We'll take the vote of thanks. Then Mr. Alex Mensah will give us the closing prayer. Okay. So on behalf of the organizers, I express our heartfelt appreciation to the Ministry of Health, the NCD's Alliance Ghana, our development partners, the media, and all stakeholders present here today. Your contributions and insights have made this engagement both meaningful and inspiring. May we continue working together toward a healthier and a stronger Ghana. Thank you and enjoy the rest of the day. Mr. Alex Mensah, please.
Please, let's pray. Most gracious and everlasting Father, we thank you for yet another day. We thank you for a very successful meeting. We thank you for bringing us together to harvest ideas on the way forward towards caring for the people you love so much. It is our prayer that you continue to give us the strength and the wisdom to be able to implement the decisions taken. As we leave, we ask for your grace and for your guidance. When we reach our destinations, we continue to say, thank you for being with us. We bless you in Jesus' name. We pray. Amen.
So quick one, we want to acknowledge our sponsors again. So to the Ministry of Health, NCD's alliance in partnership with the Leona M. and Harry B. Charitable Trust, the media, and to you as well. Thank you so much. God bless you.